The recording will be posted on the board's webpage shortly after the meeting. TBW may also be streaming this live and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the materials. Sue Birch, Chair of the Healthcare Cost Transparency Board, will now call the meeting to order.
Thank you. Welcome, board members. It is so great to see everybody in person. I didn't get to see you earlier, so good morning. It is a little after 10 and I'm calling the February 9th meeting of the Healthcare Cost Transparency Board to order. Here's that virtual gavel that I use every now and then. Those knuckles work. I really want to thank those of you that traveled down to Olympia. Those of you that are online, we are going to be welcoming you and looping you in as best as possible. So this is very exciting to have our first board retreat as we kick off the work that is going to be the next phase of our journey and our work championing affordability and cost containment. I really want to help you guys understand too, you're really important with bringing your perspectives, your stories, and your viewpoints as we continue to peel back the onion, the layers of the onion, and be on this journey together. I also want to welcome Greg Marchand. Is Greg on? Yes. Greg, you are on.
I am, thank you.
Great. Just for those of you that don't know Greg, Greg is our newest board member. He's the Senior Director of Global Benefits for Boeing Company. He's been responsible for developing the policy and strategy of the company's global benefits and health services, which includes healthcare and well-being, financial and retirement benefits, occupational health, and clinical services. He's also a very vocal member on the Washington Health Alliance and is involved with the Purchasers Business Group on Health. And so he has just an amazing skill set that will contribute to our work, because I think you will hear throughout this retreat that our opportunities for alignment and doing work kind of harmonized with other entities is going to accelerate our efforts. Greg, you've had so many awards and you've been called out so much. I don't want to embarrass you and go on and on. We wish you were here so we could have a coffee with you. Is there anything you want to say to the board?
I'm really excited to be, part of this group. And Sue, thank you so much for enabling that. My video's been disabled on your end, which is okay with me. If just wanted to mention that, because I'm certainly willing to join, but I'm excited to, and I know many of the other board members, but looking forward to meet the ones that I don't know. So thanks.
Great. So board members, I don't know if anybody else has anything to contribute about Greg, but please join me in welcoming him.
This is Margaret, and I'd certainly like to welcome Greg. We've known each other for decades, so it's nice to have you on the board.
Yeah, hi, Margaret. Yeah.
Hi. And also my video is frozen.
We're going to work on fixing that, board members. For those of you in the room, you will notice that we have one of the state's probably older, thriftier systems. We are always asking for budgetary increases to improve kind of our ability for hybrid meetings, but please bear with us today as we work with our cameras and whatnot. But we do have staff and technical assistants that we can try to improve things. So board members online, do chime in if we are missing you, and let us know how it's going if there are sound challenges. I want to begin today with a roll call, and then we're going to do an overview of the agenda, and then we're going to do a reflection back to all that we've accomplished and just kind of talk a little bit about the year ahead. So roll call, let's do this. Jane Beyer, and because we have some new folks and we haven't been in the room together, will you everybody just remind each other who you're with, and for those of us that have not met in person or are new to the board. So Jane Beyer.
Hi, everybody. I'm Jane Beyer, and I am the Senior Policy Advisor at the Office of the Insurance Commissioner. Many of you know me, an old hand around here. I've been a legislative staffer, the State Medicaid Director, the State's Behavioral Health Commissioner at various points, and have been with OIC since 2017. And happy to be here on behalf of the commissioner.
Thank you, Jane. Eileen Cody.
I was in the legislature for a few years and was the chair of the healthcare committee, and I am the consumer, actually lucky enough to be representing consumers here now. And I don't know, that's about all I have to say.
She's a chief health troublemaker.
Yeah, I tried.
Lois
years.
Cook.
I'm Lois Cook. I'm from a small business owner in Vancouver, Washington, America's Phone Guys. I am new to all this healthcare stuff over the past couple of years doing this, so very interesting and I've learned a lot.
Great. Bianca Frogner.
Hi, I'm Bianca Frogner. Unlike my title that's on here, I'm a professor at University of Washington and I direct the Center for Health Workforce Studies, where I've been for the last 9 years or so. So it's been a pleasure to be part of this. I'm a health economist, not a clinician, even though I sit in a school of medicine. So I'm glad to be here.
I don't know where that title came from.
Yeah. Mark was like, I'm like, no. I'll take it, yeah, title.
We apologize for that, Bianca. Yeah, we like to get other things really accurate, but apologize for that. Jody Joyce is not with us today. Jody has let us know that she has some circumstances. She is very committed to this, but we may not see her for the next few meetings while she gets some personal things under control. But Jody is our nurse practitioner that is been very involved. Greg Marchand, we know you're on, Greg. Great. Next
Yep.
is Mark. Thanks, Greg. Mark Siegel.
Mark Siegel, and I'm with Costco, and I've been with Costco for a very long time. That's kind of how we do it there. I oversee the benefit department and a few other things as well. And benefits are part of our culture. Like to take care of people. We don't have a high deductible plan. We have one plan. So it's just kind of a big thing that we do for people. And we want to continue that, but it's getting more expensive.
You noticed that?
Yeah, yeah.
And Mark, just have to say, I shared this with Mark, that I have never met a Costco employee that doesn't absolutely right from the get-go talk about how happy they are and their wellness benefits, but I think.
I talk to a few.
Yeah. It's not all.
They find me sometimes, yeah.
All right, Margaret Stanley, I know you're out there.
Yes, greetings from Florida. I am retired. Some of my previous jobs were as the first director of the Healthcare Authority and also the Puget Sound Health Alliance, now the Washington Health Alliance. And I don't have any video at this point.
We're trying to fix that, Margaret.
Thank you.
I'm sure that you're able to. You just have to accept as a co-host. Did you accept as a co-host?
Margaret, I'm not
Not analyst.
Panelist.
I
Mark-
accepted as a panelist.
Did you just, that's okay. If you got a recent email, would you be able to accept it?
Did I get an email?
Yes, I believe so. Is that correct, Jesse?
I don't know. I'm reluctant to
You're
leave
not
the
fine? Okay,
site.
yeah, we're good.
Okay, Ingrid Ulrich.
Hi, good morning, everyone. Ingrid Ulrich, pronunciation. I'm the CEO of the Washington Health Benefit Exchange, and I'm really honored to follow the footsteps of Pam McEwen. And also work in partnership with Leah Hall Marshall, who's back there, and a deep expert in these topics. So thank you so much.
Kim Wallace.
Hi, good morning. I'm the medical administrator at Labor and Industries, Department of Labor and Industries. So I co-lead the Office of Medical Director with Dr. Gary Franklin. And my work in healthcare has been, gosh, the years are racking up now. But I have worked in benefits purchasing and benefits management and a bit of health IT and a lot of public health as well. So this is such important work. Very glad to be a part.
Before Ellen and I, a long history with our pet programs.
Yes,
And
yes.
also with, over at Department of Health with, WIC.
Yes, yes.
Great public health perspective. And Carol Wilms.
Carol Wilmus with the Association of Washington Cities. I've been with AWC for 41 years and started when I was very young, clearly. And I've had many roles at the AWC over that time span, but my favorite role is the current role, and I'm a director of member pooling programs at AWC, which encompasses our healthcare program statewide for city and local government employees, and also a property liability pool, a work comp pool, retrospectively rated pool, and also a drug and alcohol consortium for US DOT testing. Our largest program is our health pool, and I'm really happy to be here in person with all of you today. It's good to see your faces.
And you too are an Alliance member.
I am, yes.
And you have a huge wellness fair coming up soon.
We do,
So-
we do our Healthy Worksite Summit. Yeah, private and public sector employers, it goes about 400 strong.
That's great.
Yeah.
So welcome. Those are all the board. Oh, Edwin, I'm sorry, Edwin, are you on? I think he was gonna be in and out today. We have Edwin?
I did not show it.
So Edwin Wong is our other member and he will be dropping in and out. And Edwin is an amazing economist, health economist at UW. And I cannot remember the number of his center. Bianca's chewing, but he will be in and out, so.
He has a joint appointment between the school public health, health systems and population health department and the VA. Puget Sound, where and I think he's affiliated also with the Choice Center, which I can never remember the acronym. I'm looking at Joe. I don't know if you happen to know. It's a health outcomes and economics center.
He also does work with Vessel too, because he was on a project that we recently did with Vessel.
Oh, that's right, Bethel. Yeah. Jake can't remember that value.
Value System Science Lab.
We're very excited about the mix of our board members. We still have an SEIU position open and we are still trying to recruit for that position, just so folks know, but we are pretty much fully seated. So we're working on filling that last vacancy. Before we move into the overview agenda, I do want to just acknowledge that typically over the past few years, we have gotten into a little bit more of an acknowledgement around land use and recognizing kind of our partnership with tribes. But I'd like to pivot a little bit today and just share with you very briefly. This is Black History Month, and there is a fascinating book about Blacks in Thurston County. And I think I just want to share with you because I think it's so important. I know in my upbringing, I have not had enough exposure to stories, but right here in Olympia, a young gentleman, an African-American's family, moved to Olympia in 1945 from Anaconda, Montana, where his dad was involved in railroads, bringing railroads across the US. And Avis Dennis had a special aptitude for math and statistics. He did really well in high school. He did really amazing things. He went on to begin at the University of Washington up in Seattle, and he settled down here in Olympia in Thurston County. Graduated in 1938 with the first, he was the first Black student to graduate with an advanced degree in engineering from UW. Then it went on to serve in a state engineering role. He had to leave Olympia though. He moved his family up to Tacoma and then up to Seattle because the community refused to rent to the family. And this book chronicles the amazing stories of many significant African Americans that have prevailed in Washington. And I just think it's really important. He passed away in the late 70s. His son went on to be a colonel in the anyways, I think it's really extraordinary. If you get an opportunity or if you're interested at all, there are some amazing stories about Black history in Washington, and this one specifically towards Olympia. And when you hear about his contributions to the state and his work in transportation and engineering, it's really pretty remarkable. So just wanted to share that with you all. We have extra books too, if anybody wants to view. All right, now we're gonna move into business. I wanna go through the agenda. I also want to introduce Liz Arjun. Did I say that right, Liz? and Gary Cohen from Health Management Associates. We refer to them as our HMA partners. Health Management Associates, they're going to be working with HCA to provide subject matter expertise, deeper facilitation in certain areas, and strategic planning to support the work of the Healthcare Cost Transparency Board. Gary and Liz, why don't you tell us a little bit about yourselves, and let's see, yeah, why don't we start there?
And I see that Gary is on camera. We also have another colleague, Craig Schneider, who's going to be joining. He is new to doing the work in Washington, but thank you, Sue. I'm Liz Argent. I'm a principal at HMA. Many faces are familiar around here. I've had the opportunity to do a lot of work with many related initiatives over the last more than 20 years here in Washington. And so it's really exciting to be a part of this work. For folks who don't know me, I started out as an advocate working on issues for children and vulnerable populations. And it's really exciting to see the energy coming together around addressing healthcare affordability, and HMA is really honored and thrilled to be a part of this work and help you all, move this forward. I'm going to introduce my colleague Gary, and then Gary, if you want to turn it over to Craig, that would be great.
Thanks, Liz, and thanks, Sue. My name is Gary Cohen. I'm a principal at HMA based in our San Francisco office. And during the 2 years that I've been at HMA, I've actually done quite a lot of work for various agencies in the state of Washington, including the Exchange, where we've been doing some strategic planning work with them, the Healthcare Authority, where we've been helping to facilitate the work of the Universal Healthcare Commission, and most recently, working with the Office of the Insurance Commissioner on the affordability report, which Jane will be talking a little about later in the meeting. Before joining HMA, I spent 5 years as head of government affairs for Blue Shield of California, and was very much involved in the policy and advocacy that led to California's legislature adopting an Office of Healthcare Affordability, which is similar to the work that you all are doing. And before that, I served in the Obama administration for 4 years, from 2010 to 2014, working at the Center for Consumer Information and Insurance Oversight, or CISIO, which you may be familiar with, was the entity that was set up to implement the Affordable Care Act in the private insurance market, where I was director of the oversight group. And then for the last year and a half of my time there, I was director of the agency. And responsible for helping really all of the work, including setting up the exchanges and kicking off the first open enrollment period in 2014. I'm thrilled to be working on this with all of you. I don't know if Craig is on or not, but if he is, I will hand it off to him. I'm not sure, Liz. I'm not seeing him.
If he's not on there.
Thank you, Gary.
Yes.
I also want to just recognize we have several very esteemed colleagues in the room, and I think it's important right from the get-go. I know we'll be hearing from them later, but I'd like to also recognize Joe Dealman from IHME. We also have Leah Cole-Marshalls back there from the Exchange. He's strategic leader at WABI. We also have our very own Vishal Chowdhury, our Chief Data Officer. Vishal, do you want to introduce some of your team?
Cheryl, she's our U.S. member of the Passport Data Analytics team. She leads the team now.
Great, thank you. And then lastly, we have Drew Alberio, who is the president and CEO. He's in charge of the Washington Health Line, so we really appreciate, Drew, you coming down and spending the day with us. We also have some of our own staff members that are at the table. Do you want to do a quick introduction in case things come up?
Sure. Hi, everyone. Maybe we screen Board Commission Instructor.
Hi, I'm Rochelle Bogue. I'm the Cost and Transparency Manager.
Jessie Wolf, Administrative Assistant to Policy Division.
Thank you. And then last but not least.
Sure, Teresa Tamura, Operations and Engagement Strategist, and I work with Michelle Needham, who should be introduced as well.
Oh, last but not least.
Michelle Needham, Chief Policy Officer.
All right.
And I'm sorry, Sue, I see Craig is on now, so excuse, let's, if Craig could just introduce himself briefly too as the third member of the HMA team. Thank you.
Hi, thanks, Gary. Sorry for that. I was starting to do my intro in the chat, but now I can do it orally. Hi, Craig Schneider. I'm a principal in HMA's Boston office. I've been working on value-based payment issues for more than 20 years, dating back to my time at CMS, and I led the National Learning Collaborative for Medicare Accountable Care Organizations. And for the past 2 or 3 years, I've been working on cost growth benchmarking issues with the Peterson Foundation and trying to analyze the potential for a hospital global budgeting initiative in New Mexico. And it's a real pleasure to meet all of you.
Great, thank you, Craig. All right, so we are going to do a brief overview of the agenda. We're going to first approve the December meeting summary. After that, we're going to hear from Jane Beyer of the Office of Insurance Commissioner and Kelly Richburg from the Office of the Attorney General. Both of them will present on their affordability reports, highlighting the urgent need for policies to help curb healthcare cost growth. And they're going to be reviewing several policy considerations for controlling healthcare costs and what they have in mind as much as they can share. Then I'm excited to welcome cost board managers from across the country. They're going to present on some policy strategies they are undertaking with a focus on achieving affordable healthcare through greater cost transparency and increased accountability. Then we're going to have a panel discussion, and we're going to, again, David Seltz, Corey from Massachusetts, Corey King from Rhode Island, and Sarah Bartleman from Oregon will be just great to talk more in depth. After that, we're gonna take a short break. We're gonna go grab our lunches and come back in and have a working lunch. We're gonna have a facilitated conversation to discuss and reflect on the presentations and the panel discussion. Then we're going to move into legislative updates and information about how the session's going. And we're going to focus on legislation and impacts on healthcare affordability and cost containment. Then we're going to engage in a presentation discussion to identify the top areas for policy focus for 2024. We'll take a short break. We'll have a short presentation on committee charters, just some of our own internal business that we need to kind of tune up and shift in a new direction. And then we'll have a brief update on the 2024 data call. Lastly, we will do public comments, and then we will wrap up and send you all on your way, hopefully before traffic gets back. So we've got a really full day. It's going to be just, I think, really informative and set kind of a new tempo and pace for the upcoming year. So I do want to just also look back. And before we start moving into today, I think it's really important to recognize some of the significant accomplishments that have occurred thus far. It's no small feat, and thank you, Rep. Cody, for birthing this movement, but it's no small feat to establish this, especially in a hybrid arrangement where we have to engage so significantly with the public. Certainly during COVID and whatnot, it was a challenge. And as you all know, I think the first year of getting that benchmark work done was really pretty tough the first couple of years, but we have a great base laid. I want to remind you that we're not only 13 strong on this board, but there are over 50 committee members that populate the data committee. They populate the primary care committee and also the provider and carrier committees. And we'll be talking about that later because I'm going to count on some of you stepping into serving on some of those committees that I know many of you already are. But that's really significant. We are the only state in the nation that has these advisory committees. And we, again, we'll be talking later about how we have to kind of adjust a little bit of the information feed and flow and the work of those committees. We also created the benchmark to measure the cost growth performance of carriers and providers. We completed that first cost driver analysis, taking into the cost drivers, into account cost drivers. We created the primary care committee to measure the primary care spending. I believe we are second in the country to move deeper into that primary care measurement. And that's really important because we want that to align with some of the other significant primary care work that's happening with our partners around the country and here in Washington. We initiated the hospital cost, profit, and price analysis, and we should have a full report on that soon. We also received a 2-year, $1.7 million grant to support a new partnership with our partners at IHME. And as I said before, we're going to be hearing from Joe later on. And that's really important because we are the first in the nation to receive help from the now 6 formative foundations that are investing significantly in this work with other states and really trying to create critical mass to get a movement across the country to lift. And many of you that have national, you're not only just nested and proudly here in Washington, but that you have national influence. It's really important that we stay aligned with the national movement as well. And that takes a lot of networking and us cajoling and visiting with them as well. We also completed an analysis of the first data call with presentations to the board and its committees. And wow, that's a lot of work to get done, to get started. And I think as you will see from today that we really are going to see more and more continue to take off. So with our data and efforts to date, we're really going to get into this new phase. And the legislature's second charge to the board now is to consider policies that are going to control healthcare costs and ensure affordability for Washington's consumers and purchasers with the purpose of recommending options to the legislature. Again, we are so not alone in this work. And as we're going to hear today from other state agencies and other state nonprofits and national groups, there is just significant need to coordinate, harmonize this work so we're not doing redundant work, we're not duplicating, or we're not presenting kind of conflicting data, that we really know what each of us are doing. So that's very, very exciting. I remind you, we are one of 8 or 9 cost boards. I'm curious, I'm sure Gary will share with us at some point where we are with where California is. There's been a lot of tension with boards as they are moving forward in the information and the transparency that they're bringing forward. But there are 9 other entities like us in the country to which we'll be hearing from 3 today. So we'll keep joining those efforts. We'll keep going to those national meetings to be bringing in that kind of national information and using that to the best of our ability here in Washington. In tab 2, you're going to see our work plan for the upcoming year. And that is a great graphic of everything that's going on. I encourage you guys throughout today to just keep asking questions, keep chiming in, keep giving real life examples. I'm really inspired about this next phase of how we're going to move forward and keep putting persistent pressure on this challenge. It's really, really complex work, but I'm energized and we have simply got to keep up the appropriate amount of attention on this very key issue because it is impacting so many, our businesses and our state. So again, I want to thank you in advance for being here today. I want to thank you for leaning in. I know we here in Washington have a lot of Washington nice, but we have to continue to really just move boldly forward. So why don't we move to that third tab, and we are going to approve the meeting summary.
You. I really appreciate it.
Is that? I'm not sure who's on muted.
Margaret's up there twice.
Oh, okay.
Oh, she probably called in with her phone and didn't realize it.
Margaret-
It looks like she's muted now.
Okay. I want to remind you all that the recording of the last meeting is posted on our webpage for reference or review, and we're going to use the consensus process for a vote on the approval of the meeting summary. Is there any discussion of the December meeting summary or any proposed changes to those, to the summary? And again, it's behind tab 3. If not, is there a motion to approve?
Motion to approve the minutes as written.
Thank you, Eileen. Is there a second? Thank you, Jane. All in favor, say aye.
Aye.
Any opposed? All right. I want to ask Jane Byer now from our Office of Insurance Commission, and Kelly. Kelly's on screen. Is Kelly? Is she coming in person or? Okay, oh, there's Kelly. Great. So Jane, we're going to turn it over to you first. And then we'll move to Kelly next to begin our reports. I remind everybody that Jane's presentation is under tab 4. Take it away.
Thanks, Sue. Let's see, Jesse, can you drive if I let you know? When you need to, or Mandy, you're driving. Okay.
Jane, just try to project as best you can to our microphone, the center of the room.
I used to say I will speak as if I'm telling my children they need to behave. Okay, so a little bit of context for this report. In the budget passed during the 2023 session, the legislature directed the Office of the Insurance Commissioner to develop a 2-phase affordability approach. First, this preliminary report that I'm going to talk to you about today, and then a final report that's due to the legislature in August of this year. And with this preliminary affordability report, there have been so many discussions about, for example, the impact of healthcare consolidation nationally and what's going on nationally. And what we heard from legislators was we'd really like to have a better understanding of the structure, or what I call the business of healthcare in Washington State now, specific to Washington State. So a big part of this preliminary affordability report, and I really do want to shout out thanks to Gary and Liz and their team for their work on this, because 89% of this is their work, is to just sort of say what's the lay of the land now in Washington State, and then to lay out an array of policy options that I'll talk about. And then once we go through those, most of which are not going to be new to anybody who's sitting around this table. So let's go to the next slide. And first, I don't think I have to convince anybody in this room about the affordability challenges that consumers face. We pull together information from a variety of surveys and analyses that have been done. Too many consumers are foregoing healthcare or taking on debt in order to pay for healthcare services. For employers, we did a study of the commercial healthcare market that we regulate, fully insured health plans that we regulate, and we saw costs in commercial health insurance increased by 13% between 2016 and 2019. That was about twice the rate of inflation. And then the legislators will often remind us that the state spends 20% of its general fund budget on healthcare. And years ago, when it was popular, healthcare used to be called the Pac-Man of the state budget. And it's probably still true. Next slide. So I indicated here, I already talked about the direction that we got from the legislature, and to do this work in partnership with the Office of hca, and they've been lovely partners in doing this work. Next, please. And again, I think I already talked about these, so let's go to the next slide and get down to the details. So what do we know about our healthcare system? Right, 40 of the 100 hospitals in the state are part of the 5 largest hospital systems. All of the multi-hospital systems in the state control about 80% of the hospital beds in the state. And often when people talk about consolidation, they talk about hospital to hospital consolidation. But what we're also seeing a great deal of is vertical integration. So as you can see, 82% of hospital systems owned hospital affiliated clinics, 28% owned freestanding clinics. And there with the freestanding clinics, we have all the issues related to facility fees that many of us have talked about. 13% own a home health agency. And we think at least 50% of physicians in the state are employed by hospitals. And of the 65%, or about 2/3, are employed by multi-hospital systems. I presented to a group of the Washington Academy of Family Practice a couple of weeks ago, and in a room of about 60 either practitioners or residents, there were 3 docs who still had independent primary care practices. That was it. So they sort of rolled their eyes when I talked about things that we can do to support independent practitioners remaining independent. And it was sort of like, yeah, been there, done that. So it's definitely it's the predominant model. But then we didn't want to limit our look to what's happening among healthcare providers. We said, let's look at what's happening among healthcare insurers. And we saw a lot of vertical integration by not just the insurers, but their holding companies. So, for example, United Health Group is the holding company, and they own Optum Medical, which now employs 90,000 physicians nationally. That's a lot of docs. And what we found is that insurers or their holding companies have integrated with PBMs, right? Pharmacy benefit managers. CVS bought Aetna. United Health Group owns Optum. So their pharmacy services in terms of owning pharmacies, healthcare benefit management services, and then a lot of the carriers in Washington state are also third-party administrators for major self-funded plans. And all the way down to owning data and analytics. Another example with United Health Group is that they own an entity called Change Healthcare, which is a big data analytics entity. And Change Healthcare owns Interqual, which are clinical guidelines that are used throughout the nation to guide medical necessity determinations that insurers and self-funded plans make. And so, as you can see, we've got a lot of horizontal, we got a lot of vertical in the state. And so any health policy issue that we look at comes down to, okay, this is the world that we're in. How do we respond to the world that we're in? Next slide, please. And then we asked the folks at HMA to take a look at private equity acquisitions in Washington state. Clearly, we've been hearing a lot about it as a growing national trend. We found a meta-analysis of 55 studies that basically said that PE ownership was most consistently associated with increased cost to patients, with mixed results on impact on quality. We see key investment areas being specialties like dermatology and ophthalmology. Other healthcare services, we're seeing a fair number of acquisitions of behavioral health hospitals by private equity. Because God only knows if COVID taught us anything, it taught us that there's an increasing demand for behavioral health services. And we looked at Washington state from 2014 to 2023. HMA found 97 healthcare acquisitions by private equity entities in Washington state. And for example, US Anesthesia Partners operates in Washington state. They're a PE-owned group or PE-financed group that operates in 8 states. And then Team Health also has a number of contracts to operate or to staff emergency rooms, and they also have private equity backing. And so then what we did is we said, let's look at affordability policy options. This circle is sort of hard to read. But I know whenever we present, we try to give folks an understanding of who's getting their coverage where in Washington state. And so we know Medicaid is a couple of million folks, Medicare is about 1.5 million folks. And when we look at sort of the landscape of employer health insurance and individually purchased health insurance, the Office of the Insurance Commissioner regulates the individual market, so the plans that are sold on health benefit exchange. We also regulate small group and large group fully insured plans, but we always like to note that probably at least 2/3 of the folks in the state who get employer-sponsored care get it through a self-funded group health plan. And under federal law, like AWC's self-funded group health plan, for example, or Costco's, and that under federal law, under the Employee Retirement Income Security Act, states cannot regulate self-funded group health plans. I will say that in our state's Balanced Billing Protection Act, which legislature passed back in 2019, because there were more consumer protections by virtue of that law, we gave self-funded group health plans the option to opt in to our state law so they could provide greater protections to their employees. There are about 450 plans that have opted in, and I think AWC is one of them, Carol. And that represents about 500,000 covered lives who are voluntarily coming into a state program that provides greater protection than federal law does.
Jane, is public option captured in the individual?
individual.
Thank you.
Yep, they're in there. Okay, next slide. So we worked with HMA to come up with a list of healthcare policy options to examine. And really, this report is just sort of, here's the menu, here's sort of a description of the policy, here's what's happening in other states, and here's where we are in Washington State with respect to the option. So I'm gonna run through these pretty quickly, or Steve, let me know how many more time. Not much. Okay, so really quickly, healthcare cost growth benchmarks, that's this board. So we can, I think, go by that one. Okay, health insurance rate review. In Washington State, our office has authority to review individual and small group health plan rates. We do not review large group rates. That's really common among the states. In a few states, Rhode Island probably being the biggest example, they have undertaken more aggressive rate review that has specific caps around rate increases, for example, for hospital services. So if anybody is curious about that, you can ask Corey about that when he speaks. Next slide. Reinsurance. Reinsurance essentially is a mechanism. It doesn't get directly at cost. What it does is pull the highest cost folks out of a pool, which lowers the cost of insurance for everybody who's purchasing in that pool. It's been done in 17 states, and it has been shown to lower premiums for people who are buying. We actually considered it in 2018, but didn't enact it because of state funding that the state would have had to come up with. That's a whole story in and of itself. Next slide. Reference-based pricing. There are a couple of states, Montana and Oregon, we can also ask Sarah about this when she presents, that are essentially price setting or rate setting within their public employee purchasing programs to essentially drive down price. So this is one of the options that gets directly at price. And we've done a version of reference-based pricing in our public option plans that set the aggregate reimbursement at 160% of Medicare. Next slide. All payer model. This is one that will be getting a deeper dive because the legislature explicitly said in their guidance to us that we should come up with a feasibility model for a hospital global budget system in the state. And that will be modeled. And I think what we're going to do is we're going to model one urban county and one rural region to just get a sense of what the difference would be between urban and rural. Next one. Facility fee reform. I think we've all heard about with hospital acquisition of provider practices, the addition of facility fees, in addition to the professional fees that would be charged, for example, for the physician services. A few other states have addressed this. Most have focused on sort of transparency. Connecticut's probably been the most aggressive state. We have a notice requirement in Washington State, and also there's reporting by hospitals to the State Department of Health around revenue that they get from facility fee. Reporting has been a little bit spotty on that one. Next one. Medical loss ratio requirements. Folks know that the hca set caps on what percentage of premium insurers can spend on their admin costs. And so here it's looking at making that medical loss ratio a bit more aggressive, so there's less spending on admin costs. And for example, Massachusetts has an MLR of 88%. Next slide. And of course, public option plans, Washington State, Colorado, Nevada, sort of leading the the progress on that one. And we are clearly seeing growth in enrollment in the public option plans, especially this year with this year's open enrollment. And I'm sure that Ingrid would be happy to answer any questions on that one. Next, state exchange subsidies. Washington State Legislature appropriated funding for additional subsidies to make coverage even more affordable. Gets at affordability, doesn't get at price, right? Next one. Come back. Okay, prescription drug pricing. Washington State's Prescription Drug Affordability Board had its first meeting in October and is getting off on a good footing. I think Cody is on the PDAB as well. She's everywhere. 8 states have implemented programs to address prescription drug affordability. And so again, sort of like the Healthcare Cost Transparency Board, all of the PDABs across the nation are sort of like always talking to each other and learning from each other. Next. Individual mandate, we put this on here only because the ACA used to have an individual mandate, it no longer does. The big problem in Washington State is Washington State doesn't have an income tax, so very, very challenging to implement an individual mandate. I think that might be it. Right, next steps. So just super quick. Again, our final report's due to the legislature in August. We are the folks at HMA and their actuarial firm Wakely are doing a deep dive on several of the options that we just reviewed. One of them, again, is the global rate setting because we have to do that one. I'll let folks know that another one of the deep dives is Healthcare Cost Transparency Board and what the impact is of setting different growth targets. And there are several others that you'll see in the final report. We're trying to have a mix of strategies aimed at insurers, strategies aimed at providers, strategies that get directly at price, and strategies that, for example, like reinsurance that sort of get at affordability without going directly at price. So that's where we are. Lots of fun work.
Jane, thank you. Very thorough presentation. Why don't we hold questions and then hear Kelly's presentation and then we'll move into questions for both of them. Is that okay? So Kelly, Kelly Richburg is here with us from the Attorney General's office. Kelly, over to you.
Good morning. Thanks for having me. Again, I'm Kelly Richburg. I'm with the policy unit at the Attorney General's office, and I'll be speaking about the Attorney General's office contribution to the Healthcare Affordability Preliminary Report. We were charged with examining approaches used in other states to address consolidation and promote competition in the healthcare marketplace. Specifically, this presentation will cover laws that require healthcare entities to notify state agencies before completing a merger, acquisition, or other affiliation. So I'll be comparing what's currently done in Washington to a few other states. I'll also briefly touch upon contract clauses that can be anti-competitive. The report itself also has a section on the legal landscape. I won't be speaking about that today, but if you are interested in case law on antitrust oversight in healthcare, you can find that in the report. I will briefly begin with why consolidation is something to care about. It is linked to increased prices, which can be passed on to patients in the form of higher premiums and out-of-pocket spending. And those increased prices often come without any improvements in the quality of care. So paying more without getting anything better. And consolidation can also have impacts on healthcare labor markets, such as suppressed wage growth for those working in hospitals and degraded working conditions. And an example of that is providers seeing more patients per day without an increase in wages. And of course, these negative impacts don't occur in every transaction, but given the potential for negative impacts, states have enacted notification laws that give them some visibility into these transactions before they occur. And some states do have the authority to approve or restrict transactions before closing. So I'll start with talking about what's happening in Washington currently. In Washington, a notice requirement has been in effect since 2020, and that is in Chapter 19.390 of the RCW. It requires healthcare entities to provide a 60 days advance notice to the Attorney General's office before undergoing what's known as a material change. And that includes mergers, acquisitions, or contracting affiliations. And this gives the state information about transactions that fall under the federal threshold for notice. So at the federal level, what's known as the Hart-Scott-Rodino Act requires notice to the Department of Justice and the Federal Trade Commission for transactions valued at more than 111 million. When the legislature created this notice requirement at the state level, they noted that it was intended to supplement that federal law and give the Attorney General information necessary to determine whether an investigation under the Consumer Protection Act is warranted for potential anti-competitive conduct and consumer harm. So in some ways, what we have currently in Washington is broader than what's in other states. Only a handful of other states require this type of notification for anything other than hospital transactions. And Washington's requirement does cover physician groups with 7 or more providers. We also do not have any revenue thresholds for the notice. So this is in contrast with Oregon, for example, where notice is only required if one of the parties has at least 25 million in revenue and the other has at least 10 million in revenue over the prior 3 years. And then in other ways, Washington's law is narrower than other states. Next slide. Our law currently is a legal review for antitrust concerns or harms to competition. A few other states have broader processes in place, so their review is going beyond that legal review, and they are assessing things like harms to healthcare access, quality, and equity concerns. So on the next slide, I briefly have some information about a few other states with different types of programs than Washington. The program in Massachusetts has been around the longest, and what may be of particular interest to this group, one factor that they're looking at in addition to competition is whether the transaction will impact the healthcare cost benchmark. Massachusetts, we learned, has reviewed about 162 transactions since 2013. And they did about 9 more in-depth reviews, which are called cost and market impact reviews. In Massachusetts, they do not have the authority to challenge or restrict the proposed transactions. What they do is produce a public report, and that can be used by regulatory authorities. In contrast, in Oregon, the program is new. It's been around a couple of years, and they're considering a number of additional factors, including cost to consumers, access to services, health equity, and healthcare quality. And they are responsible for approving with conditions or disapproving of transactions. So they have that enhanced authority. And they have approved with conditions about half of transactions to date. And to give you a few examples of what those conditions can be prohibiting facility fees, banning restrictions on employment opportunities for former employees, maintaining access to specific services for a period of years. For example, I've seen orders that require the entities to maintain at or above the current service level for OBGYN, behavioral healthcare services, and primary care. They also may state things like maintaining current service levels or referral policies for reproductive services, gender affirming care, and end of life services. And the focus in these states is really on transparency. This slide shows the information that is publicly available in Massachusetts and Oregon. So it's very different than a legal process, which is often shrouded in secrecy. These states are really describing that the public transparency and involvement is a cornerstone of their programs. And Oregon mentioned that the issues that come up during their public comment shape how they review the transactions. And so there is a bill currently going through the legislative process in Washington that would create a transaction review with some of the same features as Oregon. And that is Senate Bill 5241. It's known as the Keep Our Care Act. It was just voted off the Senate floor last evening. It still has to go through the House. But what it would do is expand the review to consider whether a transaction would impact accessible, affordable healthcare in the state. It would give the Attorney General authority to place conditions or modifications on a transaction or disapprove of a transaction without going to court. And it would require the Attorney General to monitor transactions for a period of years after they occur. So we'll see how that transpires throughout the process. Briefly touching on anti-competitive contract clauses. One example of one of these clauses is an anti-incentive clause. So this would require an insurer to place all physicians, hospitals, and other facilities associated with the dominant healthcare provider in the lowest cost sharing category, even if not all of those providers should be in that category based on their prices or their quality. And this can limit the ability of insurers to direct patients to higher value providers or require patients to pay a higher copay for higher cost providers. And ultimately, this can harm patients since those increased costs will be passed on to patients and their employers through increased premiums. So what we learned through our research for this report is that their states are starting to ban some of these clauses legislatively rather than challenging them through a legal process, since that can be very time consuming. A ban has been considered in the past as well as in the current legislative session in Washington. The most recent bill, House Bill 2066, is already dead this session. And then one other type of contract I'll mention is a non-compete agreement. And generally speaking, this is going to restrict a worker from seeking employment with a competitor or from starting a competing business over a particular time period or geographic area. And these can lead in any industry to less job mobility, lower wages, increased prices. And one of the reasons they can be a particular concern in healthcare is they can prevent physicians from continuing care for patients if they leave a particular practice. So since 2020, non-competes have been unenforceable in Washington for employees and independent contractors if they make below a certain earnings threshold. And in 2023, that was around 117,000. And Washington, along with about 7 other states, have these bans specifically for low-wage workers. Some states have gone beyond that and are restricting non-compete agreements outright. And then other states have specific restrictions on non-competes for physicians and other healthcare workers. For example, Rhode Island, Delaware, Massachusetts, and New Hampshire ban physician non-compete agreements specifically. So I will wrap up there. I've already covered this legislation, and in terms of what's next or how the board might weigh in, you might be interested in following what happens with the Keep Our Care Act legislation. If that does pass, there will be opportunities for public hearings and other ways to provide public comment on proposed transactions. So that may be an avenue for you to get involved in the future. So I will leave it there and take questions.
Great, thank you. Thank you, Kelly. Questions now for either Kelly or Jane? Anything from the board? Yeah, go ahead, Lois.
Did any of the states who banned non-compete set a limit to the size of the practices or the value of the income on the practices, or was it just straight across?
So the states that I mentioned have an outright ban on non-competes for physicians, and there weren't any income or practice size thresholds. And then there were a number of additional states that did have more restrictive bans so related to healthcare and physicians specifically, but not across the board restrictions. So to give you an example of one of those, there were some that were very specific to physicians treating a rare disorders. They could not have non-compete agreements. And then some specific to rural areas, for example, Florida. So it does vary. There are some that are outright and others have more narrow tailored restrictions for physicians or other healthcare providers.
Thank you, Kelly. Next question is from Ingrid.
Hi, Kelly. Thanks for the presentation, wish you were with us and hope to meet you soon. Question is the pace of these mergers and acquisitions. We've seen a huge amount of activity, and now we're feeling a greater sense of urgency on consumer protections. But what do you anticipate for the future? Will that continue an upward slope, or has so much activity happened that we're going to be going into a downward slope on this type of activity?
I don't have a particular prediction on that front in terms of whether transactions will slow down, stay at the same pace, or increase. I know that private equity continues to be a concern, and though we didn't have any Washington specific figures in our section of the report, over I believe a 10-year period, there was a 6-fold increase nationally in private equity related transactions. So that may be something that continues to be occurring going forward.
Thank you. Other questions from board members? Bianca.
Just a quick clarification question. So in the earlier part of your presentation, you mentioned how some of these mergers and acquisitions have a preliminary report, and then there's a more comprehensive report. Can you speak a little bit more to what is in that comprehensive report? What kinds of things are looked at? And you mentioned that then as a result, it can go into other investigations. What happens to these reports? Other states?
So in other states, such as Oregon and Massachusetts, they do have the 2-tiered level of report or review process. And I see that you are speaking with Sarah Bartleman, the leader in Oregon, spearheading that program. So she could probably give you more detail than I can, but the comprehensive parts of the review often involve engaging external consultants and experts such as actuaries and economists to do really a deep dive into the transaction and the potential impacts that it will have.
So Kelly, just adding on to 5241, the bill that passed last night, it focuses in on several things. It focuses in on whether a transaction is going to have an impact on access to reproductive care, end-of-life care, gender-affirming care, in addition to looking more broadly at potential impact on access costs. But that bill, this is the fourth year that it's been considered by the legislature. One of the key focus areas of it has been access to that set of services, whether it will be impacted by an acquisition.
Kelly, I'm wondering, as both you and Jane are digging deeper into this work, I'm hearing that many other states with academic health centers, there are unique kind of challenges or thoughts there regarding kind of involvement with education. Are you aware of any other AGs in the country that are beginning to look at that linkage between education and academic health center provisions? Or any of the complexity of consolidation with joint appointments and everything that goes on?
I am not aware of anything specific to that.
I'd make sure to keep monitoring Vermont. I understand there was some very interesting tension between their kind of oversight board and the university. So I think it's starting to play out with, again, some of the consolidation in the ownerships and the pervasiveness of cost. All right, thank you both so much. I think with that, we're gonna pivot to our next set of presenters, and Kelly, we invite you to stay on to hear this. I want to welcome David Seltz, who is the Executive Director of the Massachusetts Health Policy Commission, Corey King, the Rhode Island Office of Health Insurance Commissioner, and Sarah Bartleman, Oregon's Cost Growth Target Program Manager. David, Corey, and Sarah, welcome. They have prepared short presentations about their work, and then what we're going to do is have time for a panel discussion and question and answers with board members. So to the three of you, thank you so much for pioneering this work. Keep walking with us, and we look forward to hearing what you have to say. So I think we're going to start with David. Is that right? Andy, we starting with David?
Yes.
David, you're up. Good to see you.
Great. Good morning, everyone. Chair Birch and members of the board, thank you so much for the opportunity to be able to present from across the country today before this board. I'm David Seltz. I'm the Executive Director of the Massachusetts Health Policy Commission. The HPC, as we like to call it, is an independent state agency focused on moderating the growth in healthcare costs in Massachusetts. And our overall mission may sound familiar to many of you in Washington. It's better health, better care at a lower cost for all the residents of our Commonwealth. I'm just going to provide just a few kind of background remarks about our experience over the last really 11 years in trying to tackle this generational challenge of rising healthcare costs. And then we'll hear from Corey, my friends Corey and Sarah, and then have some time for some questions. I'll just begin by saying, like Washington, Massachusetts is always proud to be on the forefront of healthcare policy. And this part of our story really begins in 2006 when Massachusetts became the first state in the country to have universal coverage as a policy goal and put in place legislation to achieve that. Today, we still are the state with the lowest rate of uninsured of any state in the country. And that effort led to the Affordable Care Act in 2010, leading to tens of millions of Americans to find health insurance. Our policy focus after we had really been focused on health insurance coverage really shifted to cost containment. Having made this kind of promise to our residents of the Commonwealth that they would be able to afford healthcare, Well, then we had to work on the affordability part of it. Healthcare in Massachusetts is very expensive. We are among the most expensive states on a kind of a per person basis for healthcare. And what we were seeing, a decade ago was really the rising cost of healthcare, which was leading to really difficult decisions from state government, operating, of course, on a balanced budget, but also for businesses, particularly small businesses. We're seeing premium growth, often double digits, and having to make choices about benefit buy down, increasing deductibles, not being able to increase wages, or not being able to hire at all for their businesses. And of course, that same dynamic was playing out with families and individuals, where whatever wage growth they were seeing was being completely swamped by increasing healthcare premiums, out-of-pocket costs, and deductibles. And so policymakers here in 2012 decided to kind of tackle this big problem in a comprehensive way, and really focused on kind of moderating growth. And I think it's always important to emphasize that point, because we're really talking about an industry that continues to grow, but really trying to moderate that growth to something more in line with the rest of the economy to avoid that crowding out kind of dynamic that we were seeing before. So the law that we passed in 2012, its central policy framework is around this idea of a healthcare cost growth benchmark. So this idea of setting an annual target in law by which we would measure and track total healthcare spending growth in the state. This idea of a benchmark and a spending target has now been replicated in 7 other states across the country, including Washington and the 2 other speakers you'll hear from today. Today, 1 in 5 Americans live in a state with a healthcare cost growth benchmark. We were the first state to put this forward. And with the healthcare cost growth benchmark, the legislature also established a brand new independent state agency called the Health Policy Commission to really be able to monitor, track, and hold the healthcare system accountable to these new targets. This new independent agency works with another existing state agency called the Center for Health Information and Analysis. We call them hca. hca is really the data repository for the state. They're the agency that kind of collects our all-payer claims database and hospital information, case mix information, and is really kind of the data hub. We think of the HPC as the policy hub. We're the agency that takes all of that raw data and analyzes it to try to understand what are the cost drivers, in what sectors, in what services, in what geographies, for what types of patients, where are there opportunities that we can see in the data and the information that could generate savings that won't compromise access or quality. And we make these policy recommendations both to the market in general, as well as to policymakers, and also to be a trusted public resource for the legislature and for the public at large. A little bit about our structure really quickly. I'm the executive director. I report to an 11-person board. The board is appointed by our governor and other constitutional officers. The board, for the most part, is citizen experts in healthcare. And so our law required that there be an expert on behavioral health, primary care, consumer advocacy, labor, et cetera, to really represent a cross-continuum of policy interests in healthcare. We do have the Secretary of Health and Human Services and our Budget Secretary, Administration and Finance, are ex officio members. So there is a connection to the executive branch through their appointments. Me as the executive director, I was the first employee of this agency a little over 11 years ago. I started in January 2013 as employee number 1. Today, we have a staff of around 65 employees, all professional healthcare experts, data analysts, and thoughtful professional staff. We also contract with external experts as needed on our different responsibilities. So at the HPC, we do not set pricing. We are not a price regulator. Our mission and goal is really to act on behalf of the public in terms of influencing and hopefully making sure that we're meeting that healthcare cost growth target by all of our different levers. And briefly, some of those levers are our research and data analytics. As I mentioned, this has been something where the legislature in particular has often asked us to do special reports on, for example, the impact of COVID-19 on the healthcare workforce, the impact of telehealth and how we might think about telehealth reimbursement, and other topics of interest like health disparities and health equity. We're also what we call a partner. We have invested over $100 million in grants to provider organizations across the state to help them be able to experiment and innovate new ways of delivering care. For example, one of our programs right now is around supporting the provision of doula care for Black birthing women in the state with the goal of reducing maternal morbidity disparities. We're a convener. We are a public agency just like this one, and all of our meetings are done in public. And one of our signature events every year is a cost trends hearing, where we can call the CEOs and leadership of all of the state's health systems and health plans to testify and answer questions under oath before our board and before the public. And then finally, we act as a market monitor. And you had just heard from Kelly about our process by which we receive notices of market changes and can review those market changes in a two-step process, a preliminary review, and if we think that there's a significant impact, a fuller, more fulsome cost and market impact review. So those are our kind of levers: research, data, partner, convener, market monitor. How have we done? So we have now about 11 years of experience under our belts at this. We have about 9 years of data. And if you look at our performance against the benchmark and our kind of annual spend, there are years that we exceeded the benchmark, and there are years that we came below the benchmark. And that is kind of part of the process, in my view. And to me, sometimes the more important question is why or why not in each and one of those years? What do we see in the data that's really driving that? And how might we change our policies to impact that? Over this time period, our average annual growth in spending has been 3.55%. Our initial target was 3.6%. And so we have been below that initial target for this entire time period, even including the 2 years of the pandemic. Interestingly, in the 2 years of the pandemic here, in 2020, we had a negative spending growth as there was much care was being delayed or not in person. And then obviously in 2021, a big rebounding of spending as care came back into the system. But if you average those 2 years out, it was actually 3.2% average annual growth. In addition, when we look just at the commercial market, and so we just isolate kind of commercial spending, in 8 out of the 9 years, our growth in commercial spending has been below the US average. This is a reversal of a trend that existed before the establishment of this law in the HPC, where for many years, Massachusetts commercial spending was much greater than the national average. Just the delta between our experience and the US average is cumulative of over $8 billion. If you think about the difference if we had grown at the US average just in the commercial space. And then finally, I'll just highlight that when we have done these market reviews, as mentioned, we do not have the ability or the authority to outright deny a transaction. Our role is really to provide a comprehensive public report about the potential impacts of those transactions. But we have found that even this public transparency and this reporting has had significant impacts on how the state has regulated many of these transactions. The most recent transaction that we did this kind of comprehensive review on, we had identified concerns around market leverage, increasing pricing, access to care for Medicaid patients, and investments in behavioral health. And we did this all in a big public report. And then our Attorney General's office and our Department of Public Health actually imposed significant multi-year enforceable conditions to alleviate some of the concerns that we identified, including price caps on the organization, for a number of years, and requirements that they invest in behavioral health care and invest in expanding access to Medicaid populations. So despite all of that, I think really significant progress over the 11 years, I will say that I am concerned about what I see in some of the data and for the future. And we have made a significant set of recommendations to our legislature around policy changes that we think are necessary in order to be able to continue this progress for the next decade. Many of those recommendations I have already heard you talk about today with Jane and with Kelly. I'm happy to talk more about those when we get into the public session, but we'll end just by saying that all of these states that you'll hear from today, we are a part of a, I think, learning collaborative in many ways. And I have always looked forward to learning from Washington, from Oregon, from Rhode Island, and look forward to this kind of continued journey as states learn from each other. And so I'll leave it there and happy to take questions in a little bit.
Thank you very much, David. We're gonna do questions in just a bit. You guys you inspire us 11 years in, and we get it, it's very different. We've got a lot of rural areas we'd like to give you. Anyways, we're gonna move south to Corey King, and then Sarah, you'll be up after that, over west to Oregon after we hear from Rhode Island. Welcome, Corey.
Thank you very much. Good morning, everyone. I am Corey King, the Acting Health Insurance Commissioner at the Rhode Island Office of the Health Insurance Commissioner. I've been with the office now for about 10 years, and I've been the Acting Commissioner for a little over 14 months. The Office of the Health Insurance Commissioner is Rhode Island's commercial health insurance policy reform and regulatory enforcement agency. We're a bit unique in how we structure health insurance regulation than other states, in that we've carved health insurance out of the insurance oversight authority and vested it specifically within an office that can then specialize in health insurance. And when the legislature created the office, one of the purposes set forth in our statute was that in discharging the powers and duties of office, the commissioner shall view the healthcare system as a comprehensive entity and encourage and direct insurers towards policies that advance the welfare of the public through overall efficiency, improved healthcare quality, and appropriate access. So that's the lens that we apply to our decision-making across all of our specifically defined powers and duties. One of those powers and duties in law is our prior approval rate review. So similar to Washington, we approve health insurance rates prior to them being offered in the market. A little bit differently than Washington, we don't just focus on individual and small group, we also review large group filings as well. Within our rate review statutes, there's a public interest criterion and such that the insurance company has to demonstrate that the rates set forth for our review are consistent with the public interest. And from that, we have constructed a set of affordability standards that insurers have to meet. So we've been involved in strategies to reduce healthcare spending growth, because spending growth is the primary driver of health insurance premiums, and to improve the healthcare system as a whole for as long as we have been in existence. And we celebrate our 20-year anniversary this year. We were very inspired by the work that Massachusetts had done to really systematically collect data on healthcare spending and then to set a global target. Rhode Island's healthcare cost growth target is similarly constructed to Massachusetts, but not implemented in a similar manner. And by that, I mean, whereas David and the Health Policy Commission are the primary leader in terms of implementing the cost growth target, we as the health insurance regulator are the primary entity in Rhode Island. And whereas David has a citizen board, we have a steering committee that is comprised of people who have a lot of skin in the game because they're from industry. our efforts with our cost trend steering committee that I co-chair with our largest health insurer and our largest provider system. And we use the steering committee as a forum for leaders in the public and private sector to demonstrate their commitment to sustainable healthcare costs and to pair goals with actions. So some specific actions we've asked our steering committee to pursue have been development of a cost growth target methodology and a process to measure our performance against it. Unlike Massachusetts, we don't have a law that creates our cost growth target. Our cost growth target is created by compact, a local compact of interested parties. The steering committee has also advised the development of a data use strategy to inform cost growth mitigation options. And data use strategies are very important in this type of work. And then finally, the steering committee has committed through another compact to address cost growth by accelerating the adoption of advanced value-based payment models, such as primary care capitation and total cost of care models. I think one of the greatest lessons learned from all of this is that agreement on common goals within this public-private partnership framework that we have can be very difficult. So a common goal is cost growth target, for instance, but achieving agreement on strategy is even harder. I often think that the tension that we confront in Rhode Island is between having a steering committee that's really good at articulating principles and coming up with goals, but is really challenged when it comes to agreeing upon collective actions that they can then undertake together to meaningfully reduce cost growth. And that's one of the issues that I think that we've confronted as we've been doing this work for the last 5 years. Some best practices that I would share with you are ensure that problems are defined and solutions are developed in the light of day. Our work occurs in a public forum. We have public meetings. It doesn't happen behind the scenes. Data analysis and information should be based on a credible methodology and reviewed with accountable entities in advance. Public disclosure of performance against the cost growth target is necessary, but not sufficient to ensure change. And that's where I think it's important there to be some expectation that industry take collective actions to address cost growth. And then if you're pursuing any legislative initiatives, be very thoughtful and strategic about how you do that. So before I wrap up, I'm just going to identify a few of the strategies that OHIC has taken independently of our steering committee. So we came to the cost growth target concept around 2018, 2019. We superimposed that upon a system of cost containment that we already had in place through regulation, through our prior approval rate review authority, through our hospital price growth cap, and through our primary care investment target. But I felt that having a cost growth target brought a unifying logic to all the work that we were doing and allowed us to view healthcare spending holistically for all Rhode Islanders. And it provides that, like I said, that unifying logic. We publish an annual report on our healthcare cost growth where we identify and name large provider groups and health insurers, and we compare their performance against a target. We also created the OHIC Data Hub, where we have taken claims data from our all-payer claims database and have created dashboards that are interactive, so members of the community can go into those dashboards and really dig into the drivers of retail pharmacy spending growth, or dig into healthcare cost trends within mental health and substance use, for instance. And that provides us with a great deal of ability to use data strategically to support initiatives that are aimed at controlling healthcare spending growth. We've been releasing data stories. One of our data stories we released last year was looking at the association between rising healthcare cost growth and employee wages. There are a lot of important trade-offs at play when we think about rising healthcare costs and premiums, and the fact that an employee's compensation is largely driven by that. And finally, we've had some, I would say, relatively successful efforts around implementing value-based payment in the market. But we've reached a juncture where we're wondering what is the next step in terms of really leveraging value-based payment and the terms of contract as a method to control healthcare spending growth. So we could talk more about that if you have any questions later. But that's a broad overview of the work that Rhode Island is doing, how OHIC works independently, how we partner with our cost trend steering committee. And I think I will hand it over to Sarah.
Thank you. Thank you, Corey. We'll come back with questions. And board members, I remind you too that all of their presentations or supporting documents are in your packets behind tab 10. Anyways, Sarah, our neighbor to the south. Good to see you again, Sarah. Go ahead.
Great. Good morning, everybody. Thanks so much for inviting me to this board meeting. I'm Sarah Bartleman, she, her pronouns. I am the cost programs manager at the Oregon Health Authority. And I really, really love being the last speaker, especially following David and Corey, because I can just say everything that they said, and they've given you such a good grounding in where the cost growth target programs came from and what the intentions are and the structures and some of the challenges and the processes. So our work in Oregon is really heavily modeled after the groundbreaking work that Massachusetts and Rhode Island and Connecticut have laid before us. So rather than sort of starting from the beginning for Oregon, I'm going to talk a little bit about our experience specifically with our advisory body, with our governing body, and how they have been approaching strategy and policy recommendations for cost containment. Our program structure is really similar to what you've already heard about. We have a target. All of the work, the data work, the policy work is in our agency at the Oregon Health Authority. We're not split like the Massachusetts model, but guided by our advisory group, which, similar to Rhode Island, has a 50% membership of payer and provider organizations who are subject to the cost growth target program requirements. So just sort of blending all of that and talking about some of our sort of policymaking side of the world. So in 2020, Oregon's Cost Growth Target Implementation Committee initially identified value-based payment as a key strategy to help payers and provider organizations meet the cost growth target. There was a lot of traction around this. Again, because our committee, our governing group was 50% payers and providers, there was a lot of discussion about what could we do? What is within the control of payers and providers, and how can they make meaningful progress towards meeting a target? And so the committee landed on value-based payment, and they developed principles as a committee for accelerating the adoption of advanced value-based payment. That turned into the Value-Based Payment Compact, which is a voluntary agreement to meet specific goals related to the percent of payment arrangements or payments that would be in advanced value-based payment models. So since that was all sort of stood up and launched in 2020, early 2021, the compact has 63 signatories representing the majority of payer and provider organizations in the state, a number of organizations who are cross-border with Oregon and Washington. And those signatories represent more than 70% of people in Oregon. So 70% of covered lives are under the compact. The Oregon Health Authority and the Oregon Health Leadership Council, which is a public-private partnership, jointly sponsored a compact work group to support the implementation of those principles and of providing supports and technical assistance to all of the compact signatories to support this body of work. So there's been a lot of development, especially on the technical assistance and the recognizing of, what are the barriers to advancing advanced value-based payment. And they've provided a lot of resources. There's been a lot of discussion, and similar to what Corey shared, in some ways that is kind of at a stalled out point. And there's a little bit of a question of how much of this work can still continue, how much of it is still relevant, and how effective is a voluntary compact approach compared to some of the more direct, more authoritative policy options that were presented to you earlier. In 2022 and 2023, our Cost Growth Target Committee, the current iteration of that, spent some time talking about possible policies and strategies to address pharmacy costs. Pharmacy costs is one of our key cost growth drivers in Oregon, as in other states. And we really laid out the landscape and the menu of options, really a broad menu of policy options, both big P policy and small p actions that could be taken to think about where are their levers. There was a lot of conversation that our group had about what's within scope at a state level versus a federal level. Where might there already be federal action? Where is there opportunity for multi-state collaboration? And we're talking to some of our fellow states about that on an ongoing basis. And then what is within the control of a state agency or that's already being advanced. Oregon has both a prescription drug price transparency program and a prescription drug affordability board who are also identifying possible strategies and policy recommendations. And so how did that work all fit together? And I think at the end of the day, but in 2023, our committee did not land a recommendation. They were not able to get to a point where they could say, these are the policies, these are the strategies that we should advance to address growing pharmacy costs or pharmacy as a cost driver. There are a lot of challenges. That scope conversation really is hard to figure out where the cost growth target work fits and what the role of the committee is in making those decisions. I think expertise was also a big challenge. I think a lot of our committee members didn't feel like they had sufficient pharmacy expertise in a way to be able to meaningfully weigh in and make a recommendation on a policy or a strategy. So just as my colleagues shared, the cost growth target work provides this umbrella, and we really like to think about it that way. There are so many things related to cost and affordability. We can look at so many different directions and angles, but when it comes to getting to then what are we doing about it and how do we address this? I feel like we rapidly reached the end of the people's comfort zone of this is so far beyond my authority. I don't know how pharmacy benefit managers operate. How am I supposed to advise on what legislation should be to address them? So we didn't quite land that. This year in 2024, our advisory committee is restructuring how they have these conversations a little bit. They'll be reviewing cost drivers sort of by topic and then discussing policy recommendations for each. And hopefully this year we will land or surface some specific recommendations by the end of the year. So just being really candid with you about some of the challenges in this process and the tension. Your board is structured really differently than our governance structure, where we have payers and provider organizations who are subject to these policies and legislative ideas. And that really influences willingness to make a recommendation or willingness to get behind being regulated harder. So, facility fees is on the table, price caps are on the table, but, I fully do not expect any of our provider organizations to stand up and say, yes, that sounds like a great idea. We fully endorse this. So I think this year we're going to have a lot of navigation of that tension and see where we get. Also, some key work that we're doing in Oregon this year is operationalizing our accountability measures. So we also have the ability to impose performance improvement plans similar to Massachusetts, modeled after Massachusetts. But we also have the ability to impose financial penalties on payers and provider organizations who consistently exceed the cost growth target. So sort of our repeat offenders, we escalate from performance improvement plans to financial penalties. And that is turning out, unsurprisingly, to be really challenging to figure out how to do that. So how do we set financial penalties in a way that are meaningful and motivating, where it's not written into the cost of doing business or a slap on the wrist? We received public comment a couple months ago that said that financial penalties should be no more than $10,000 ever, maximum. And like that, is that meaningful? Will that be an insufficient motivation for anybody? Probably not. And so, and then if we look at some of our modeling, the financial penalties being based on the percent of overage, how far over the target are you? How much excess spending did you have? That might be hundreds of millions of dollars. And so the truth is probably somewhere between $10,000 and $200 million. But there are a lot of concerns that are raised about solvency, taking dollars from financial penalties out of the community and preventing ability to further invest in services. And, lots of things that sound really good as a talking point. So we're navigating that right now in rulemaking and trying to figure out how exactly to balance those tensions and have financial penalties that are meaningful but not destructive. So we had our first rulemaking meeting last week, and we'll be doing that for the next couple months. And then finally, in parallel, this did not launch from our cost growth target work. It was really stood up separately, but in parallel. We have our healthcare market oversight program, and Kelly gave you a really fantastic overview of that program and what we do. I just want to, just a couple of comments. Again, it didn't come from our cost growth target work, but we have directly connected the dots. So our market oversight program and our cost growth program are co-located. I manage both of them. We share staff, which is really cool because we're able to share information back and forth. And we can say, if we're reviewing a transaction, this hospital, this provider organization, what has their performance relative to the cost growth target been over the last couple of years? How are they doing? What are their key cost growth drivers that we know about from our cost growth data? And how do we think that might play out under this merger or acquisition? Similarly, we can look the other way and we can say, all right, we know that this provider organization just got acquired and all of the previous organizations in that acquisition, their prices immediately went up once they got acquired. So we could maybe expect to see that that is going to be what happens to their cost performance. We have a direct charge in our market oversight program to look at the potential impact of a transaction on the entity's ability to meet the cost growth target. So Kelly mentioned we review in our 4 or 5 domains: access, quality, equity, and cost. And explicitly in our cost domain, we look at potential impacts on the cost growth target. So trying to keep that work held together. I'm really happy to nerd out about the market oversight program, talk more about that. We provided our annual report on the market oversight program, and that's in your meeting attachment. And I will stop there.
Wow, Sarah, thank you. Well, board members, it's our time to do kind of a question and answers, just a panel discussion that continues for the next 15 minutes. I am sure many of you have questions. If you don't, I'll start off with one. But Jane, why don't you lead off?
Hey, great presentation, guys. It's lovely to see you. So in terms of the Corey and Sarah sort of stalling out on VBP, talk to us more about that. Why do you think that happened?
You want me to start, Sarah? I think it happened for 2 reasons. The accountable care organizations that are really the anchor institutions of value-based payment on the provider side are sponsored, at least in Rhode Island, by hospital systems. And the hospital systems have begun to suffer some financial challenges during the pandemic. So I think there has been some concern about bandwidth to continue expanding towards more innovative payment models, those that require the assumption of greater downside risk. That's one piece of it. The other piece of it is that I think there's a limit to the degree that provider organizations and payers want to take accountability for affordability. You know, it's someone else's problem, not their problem. And I would attribute it to a combination of those. But Sarah made the point about the environment today is very tough for cost containment efforts.
Again, everything Corey said. When we had our cost growth target public hearing in September of 2023, we actually asked all of our panelists directly about the value-based payment compact. Are you a signatory? How are you making progress? How does this all connect to you? And we had a number of providers who on the record flat out said, we refuse to accept any downside risk. This is a non-starter for us. So I think the environment has changed. The financial situation has changed. And this really varies state by state, but in Oregon, the market dynamic or the power dynamic between payers and providers and who has the power in any given negotiation. So a lot of our providers actually can say no, just hard no, and the payers need to have them in network. But that's not the case in other parts of the state. And so there's just some really interesting regionalization that's happening. The other thing I would say, maybe the other reason in Oregon, is that a voluntary effort has no teeth. And so, of course, it stalls out for very predictable reasons and I do want to give credit because some of the critics on our advisory committee called this from day one about a voluntary compact approach. And they said, whenever you have this, everybody gets together, sounds really good, everyone signs up, everyone gets the press release, and then it's just a whole laundry list of reasons why this is hard. And somehow those reasons result in never actually doing anything. And that is very much how it played out. Some of the concerns we have no training. We have no single model. We don't want to agree unless there's a single model for payment, because otherwise we'll have to have a separate contract and there'll be 20 different contracts with different arrangements and different quality measures with every single payer, and we can't handle that administrative burden, so we need a single model. So the work group said, okay, we'll develop a model. And then there were reasons why that model wasn't good enough. So I think, sort of the very expected throwing up of barriers and challenges as you go through that voluntary process that has no teeth, played out exactly as expected.
Thanks much.
Go ahead, Bianca.
Thank you for the great presentations. It's great to kind of get these deep dives on what's happening in other states. I have two questions. They're not quite the same. So one is, I'm hearing a lot of monitoring of mergers and acquisitions, but I'm curious if have been monitoring of exits from the market, provider exits, because I know that's been a concern, is that might happen. Then separately, I noticed in the Massachusetts report that it talked about how over this last, 5, 6, 7 years, primary care spending actually has been going down as a percentage. And I'm curious about the role of primary care in your conversations in your states.
Great. Thank you for the fantastic question. I'll start and Sarah can jump in too. On the market reviews, we typically get notice for a kind of a range of transactions that can include changes in ownership, but also new contracting relationships, which might not include a corporate ownership change. We also receive notices of clinical affiliations, which may sometimes have impacts on healthcare costs and spending if it's redirecting kind of tertiary referrals from one institution to another, as well as joint ventures. And it's not just hospitals, it includes doctors, behavioral health providers, home health, and we have seen over the years a range of kind of vertical and horizontal type transactions that have been reviewed to us. One of the areas, though, that we have identified as a gap in our review process is around significant for-profit and private equity investment in healthcare. And I know Jane talked about this a little bit earlier. And that, a significant investment in private equity, and then even the exit of private equity from some of those provider organizations is not something that is currently kind of part of our review process. We think that's a big gap. We're trying to get the legislature to help us change our statutes so that those types of transactions would be notified. We think these are increasing in nature. We tried to do something, I think, similar to what Jane did, and just looking at Massachusetts and where has there been private equity entry and exit in different providers. And we just had to do Google searches, and we bought a proprietary data set. It's called Trade Book or something, and that tracks these, but there is no real public resource for this. And at a minimum, we think this is really important. So encourage you, as you're thinking about market transactions that do get noticed, to be expansive in that thinking, because I will tell you, market participants are getting more and more creative in how they are structuring these types of changes to avoid regulatory and public review, whether that's kind of roll-ups or management service organizations that sometimes are shielding the investment or the corporation. Happy to dig deeper into that at another time. On the primary care piece, this is a big concern for us. We spend about 7 cents of the dollar healthcare dollar on primary care in Massachusetts, and that is a number that's going down over time. We have made recommendations to the legislature to actually set targets for increasing the proportion of the healthcare dollar that goes to primary care over time, and that's really inspired by Rhode Island. Rhode Island set in place this idea of over time kind of increasing that proportion. Our previous governor, Governor Baker, was a huge champion and filed legislation to do this, and while still sitting underneath the total benchmark. And so it's kind of like underneath the big cap, where can we try to push forward on behavioral health and primary care and set kind of measurable targets for improvement? That is another area that we've been advocating for some changes on, because I think when we think about healthcare spending, it's not all the same. And there are areas that we would advocate, even as a cost containment agency, that we should be spending more money. Primary care, behavioral health care, these are the places that's going to provide value in the long term and improve patient outcomes. But I'll turn it over to Sarah. Maybe Corey, you might want to say something about the primary care targets.
But on the primary care side, we do have primary care spending targets in Oregon, and we have explicitly written that into our cost growth target program as a good reason for cost growth. If an entity exceeds the cost growth target because of increased spending in primary care, behavioral health, no performance improvement plans or penalties will apply. That has not happened yet. Nobody has come in and that has been the reason, but it is on the list of if that is what's happening, that's great. We love to see that. That's in line with state priorities. Back to the market question. So in Oregon, our review, we do include private equity. We learned from Massachusetts and we're able to craft our regulation broadly enough that we do review transactions involving private equity. And I think it's a really interesting space because we don't officially we do not have authority for exits. We don't have authority for closures. We had a recent high profile hospital that decided they were going to close in Eugene a couple months ago. And there was a lot of like, can't the state intervene? What can the state do? Like nothing. We have zero authority. Certificate of need doesn't touch this. Like that's all about new things. If an organization wants to close or stop providing services, there is currently no state oversight. There's some legislative interest in maybe going in that direction and fixing that as a loophole. I don't know how that's going to play out. I will say that being in this position of a market oversight, doing this kind of market review has led to a lot of questions that have come in from public comment. Like now that a transaction is under review, is it the state's job to ensure that, say, the provider organization being acquired remains open? If they come into the transaction and say that this provider organization would go insolvent, they would close unless they're being bought, does that put the state in a position of saying like, now it's our job to make sure that nobody closes? So that's something we're sort of working through and what the implications of that are, but we technically do not have authority. However, I think the private equity exit is a really interesting one because if you're exiting, you're selling the control possibly to someone else, which then is a new transaction that is subject to review. And we just got our first essentially serial transaction where we reviewed a private equity entrance into a dental services organization. And now a year later, they've defaulted and they're selling their share to a different set of lenders. And so we're reviewing it again under the new fact. So in that way, we do have a lens that lets us see the exit, but not because they're exiting, but because it's a new transaction.
Thank you. Corey, and then did you have anything to add? And then we'll move to Eileen's question.
Sure. So Rhode Island has had a primary care expenditure target for the commercial market for over a decade. It's a policy lever that I'm taking a fresh look at because I think our legacy methodology for measuring primary care and crediting payments toward a target needs to be updated. And so we're actually working on regulations to do just that and set new targets, because when I see news of health systems in Boston that aren't open for new patient care, I get the sense that they're going to start trying to pick off some of our providers. So I'm going to have to incentivize a little bit more primary care spending in Rhode Island to mitigate that risk.
A little state neighbor tension there, I detect. We don't have that problem with Oregon at all, right, Oregon?
I keep hearing from local hospitals that they deserve to be paid Massachusetts prices, right? So
we hear that too. Eileen, go ahead.
David, I've got a follow-up question for you. Historically, Massachusetts, you've got more doctors per capita, I think, than any other state, right? So, and most of them are specialists. So have you guys put any pressure, the legislature put any pressure on schools, because you got a few of them, to like not be turning out as many put more focus on primary care?
Yeah, you're absolutely right with the facts. We actually have among the highest rates of per capita of primary care physicians and specialists. Interestingly, we just found this data, though. We have the highest proportion, or I should say probably the opposite, the lowest proportion of primary care physicians to specialists of any state in the country. So we are, even though we have a lot of primary care physicians, we've got even more specialists. And so, that is, to me, kind of a striking figure, and I think probably a reflection of how specialty focused and hospital focused our healthcare system is. We have had been making recommendations on kind of primary care workforce issues. As you mentioned, education is a big part of that. This is, I think, a really interesting topic for the legislature to be focused on. And at the same time, I think there are larger kind of financial structural issues when it comes to students choosing primary care versus other specialties, and where you could be an orthopedic or an anesthesia, work in, certain specialties that provide multiples of a salary of a primary care physician on regular work hours. I think there is something about our system that we pay for the most specialized care at the highest rate. And so I do think if we're going to solve the primary care problem, we kind of have to go way upstream and think about how we're even incentivizing primary care within our healthcare system. Because I think students are often looking at the future potential earnings and work-life balance, and not often choosing primary care. So how do we change that dynamic?
Thank you for that. I'm wondering, I've 3 quick things I was hoping each of you could kind of speak to real quickly. David, could you comment a little bit about your performance improvement, your PIP that was issued to Brigham and got a lot of national attention? And do you think those penalties are working, or that action? Can you comment on that? And then Corey, will you also be talking to us about your data use strategy and what that took to get that alignment? I mean, I know you've got an army of those data analysts. I think, didn't I hear you're like 50 strong on your data analytics side? And then Sarah, how much do you think the crossover between the service providers of Washington and Oregon, are there any thoughts about states regionalizing or working together, since we're even hearing Rhode Island to Massachusetts? So those are the 3 quick questions I have that if each of you could just comment on briefly.
Absolutely. I'll jump in on the performance improvement plan process. So, as we're measuring statewide annual growth year over year, our primary kind of accountability mechanism for the performance of individual health systems and individual health plans that are exceeding that healthcare cost growth target is through this performance improvement plan review and potential implementation process. So how does that work in Massachusetts? Each year, we receive a confidential list of named organizations and their contracts that where the growth exceeded the healthcare cost growth benchmark. We then conduct a comprehensive review of each of those referred entities and look at things like their spending over time, their price levels, their market position, what populations do they serve, their public payer mix, what services they provide, really trying to understand and contextualize why their healthcare spending is above the benchmark. And as part of that annual review process, we may determine, after kind of doing this thorough review, that the entity's healthcare cost growth are excessive and threaten the healthcare cost growth benchmark, and that they should be taking action to reduce their cost growth through the imposition of a performance improvement plan. I'll just make one side note that this is in Massachusetts, it's a confidential list that comes to us, and the process is entirely confidential until the point that we decide to require a provider or a health plan to do a PIP. I would not recommend that if you are thinking of that. I think there is a lot of benefit to public transparency about which organizations are exceeding the benchmark. And I know Oregon has taken a different strategy there, and I would recommend that. I think the impetus for that initially was maybe a lack of trust in the data, and are we going to be naming organizations publicly where we're not confident that, that they're confident in the data. We've been doing this for 11 years now. I do think these lists should become public and these reviews should be more public. That being said, to get to our first performance improvement plan, so after many years of kind of doing these annual reviews, and in many cases, looking at the data and electing not to require any entity to do a performance improvement plan, in 2022, we, after reviewing the data, identified that Mass General Brigham, which is our largest health system and hospital system anchored by Mass General Hospital, and Brigham and Women's Hospital had exceeded the benchmark in multiple years, contributing hundreds of millions of dollars of over benchmark spending, and should move forward and to design and implement a performance improvement plan. Then the entity itself, in this case MGB, has to develop their own plan and submit it before the HPC about what actions they're going to take in order to moderate their spending growth. That plan must be approved by the HPC. We can't dictate to the entity what that plan is, but we can consult with them about what should be included in the plan in order for it to be approved by the board. That process took about 9 months just alone for the entity MGB to design a plan and ultimately for it to be approved by the HPC board. We did approve a plan that would save, they targeted around $180 million in savings over an 18-month period of time. We had identified as one of the key drivers of their spending growth was their pricing. And I think importantly, MGB did include within their plan a number of strategies that are focused on pricing and hospital outpatient pricing in particular. And so we found that that was responsive to our concerns. We are now, fast forward to today, we are 15 months into that 18-month process. We meet with them quarterly and receive quarterly reports on how they're doing. To date, they have met every one of the benchmarks that we have kind of set forward in terms of hitting those savings targets. And at the end of the day, we then, after the 18-month implementation period process, the board then has to decide, was this successful? Was it not? If we find that the plan was not successful, then we can require them to do a new plan or to extend the plan. Or if we found that it was successful, we kind of end our engagement. So that will be the work of really the next part of this calendar year after they finish their work, is to evaluate, were they successful in what areas, and then to make a final determination about its success or failure. I would say that this is our first performance improvement plan. This was the first performance improvement plan of any organization in the country, to our knowledge. And I will give credit to MGB and the leadership of MGB, who really operated in good faith with us to develop a plan that, in our minds, has significant savings, $180 million, as I mentioned. But we have also recommended that we do need to update this statute, because I will share that under our current statute, if an organization were to not comply with this entire process and to not develop a plan or to engage with us in good faith, our only option is an up to $500,000 fine. And for organizations that have, in many cases, multi-billion-dollar budgets, a $500,000 fine, we do not find to be an effective deterrent for perhaps a future organization, not MGB, but another organization who may say, we don't want to have anything to do with this. We're not going to comply with this law. And so, sorry, we'll pay your check, fine, and we'll walk away. That's why I think we have been recommending, similar to Oregon and California, this idea of enhanced financial penalties for repeat offenders, or perhaps financial penalties that are in line with kind of the overage over benchmark. And it's not to say that we would want to then implement a bunch of those fines. That's not the point. The point is more, if market participants see this as a strong deterrent for them, or a strong incentive, I should say, for them to take the proactive steps necessary for them to control their healthcare costs so as not to potentially be subject to such a fine, we think that that would be a way to enhance and strengthen the process that we've put forward.
Thank you.
I'll stop there.
Thank you very much. That's really helpful. Corey, we have challenges in Washington around just true north data. People arguing, oh, our data is different, your data. How has Rhode Island harmonized data use and having that single source of truth? What could you suggest for our state around that data use, kind of data digestion, analytics, just that harmonization?
Sure. So we have two primary data sources for our benchmark program. One data source is total medical expense data that we collect directly from insurance companies, similar to what the Massachusetts hca collects from insurance companies there. But that data is at an aggregated level, and it doesn't allow you to tease out the impacts of utilization versus price or payment per unit, which is what you can glean from claims. You can't glean fee schedule from claims unless you dig right down to the specific procedure code. But for the total medical expense data, we've had a process in place to, once we analyze that, we then go through a data validation process with the insurers and the providers. So we show them their data and ask them for any remarks or requests for reconciliation. On the other side, in order to really decompose cost growth into its underlying drivers of utilization, price, mix, we use our all payer claims database. And we've managed to, having multiple years of experience with that database, understand its strengths and limitations and work out some of the data challenges, particularly early on. And we've convened a data subcommittee of our steering committee, which includes providers and payers, to work through different analyses and identify areas that we could perhaps study and then take action on. So right now we're looking at hospital price variation. We've looked at changes in ED severity. We've looked at specialist utilization patterns and things like that, particularly around orthopedics. So that's how we're proposing to use data to identify specific interventions that can mitigate cost growth.
Thank you. Sarah, I just was curious if Oregon's given any thought about, kind of some of the cross-state providers and systems and/or in Rhode Island and Massachusetts, if anybody's given any thought about aligned work and movement, about populations and providers and businesses that cross our states, if anybody's mapped that or looking at, are there any economies of scale or aligned efforts that could strengthen our work?
That's such a good question. And I think we've been thinking about that in a number of ways. So on the cost growth side, we absolutely share payers and providers cross-border, Kaiser, Providence, Peace Health. And that's not even talking about any of the national players like United or Aetna. I think there's absolutely opportunity to collaborate. We certainly have been talking to the program staff, and we're looking at ways to develop in alignment. So are our data collection templates similar? Are we asking similar questions? I think where that gets real challenging real fast is that often operationally, at least in our experience to date, it's the same organization, but they have really different teams. They have different arms. And so there's an Oregon market team and a Washington market team, and they might not talk to each other. And so we can try to say, hey, this is our point person. They could probably help you on the Washington side because they've been through this with Oregon 2 or 3 times already. So there's sort of the truing up of who are we talking to, who knows about this body of work, who's familiar with the data submission process, sort of more on that operations coordination piece. It might, sometimes it's the same team and sometimes it's really not. The other side of coordination is, I think, what we're going to start getting into as we continue to roll out our accountability. So this is our first year where we are going to actually make an official determination of your cost growth was or was not for a good reason. If you exceeded the target, was it for an acceptable reason or not? And we're working on defining that as tightly as we can. It's going to be squishy no matter what we do, but we're working on that. And so this is going to be the first year. And so I think there will be a lot of opportunity to coordinate cross state, where we say, are we seeing the same reasons? Is this same shared entity that is in both of our states and California too, honestly, that is in our states, are they giving us the same justification? Is it true? Is it the same driver? Is the underlying data that they're providing to us to make their case true? And this is not no one's doctoring the books in any way or telling us different stories, but I think even within Oregon, sometimes we talk to different people at the same organization about their commercial line of business versus their Medicare Advantage line of business. And sometimes the internal arguments or the internal case for what's going on is really different. And I would expect that to be even more true once we start talking cross-state. So I think there's a lot of space for us to explore how do we coordinate those conversations? If Oregon and Washington both see the same payer exceeding the target, and they're both claiming it's for the same reason, do we agree that that's a good reason or not? So I think there's a lot of that piece that's still to be mapped out. And then finally, for coordination, I think there's a lot of opportunity for collaboration and coordination on the market review side. We've been talking to Kelly and her team really closely. We're watching your legislation with interest. Similarly, we've been talking to the California team, and we're trying to figure out what does it mean to have an entity that is in all of our states that is undergoing this review in parallel. Our team and Massachusetts team are reviewing the same transaction right now involving United Health. And so we have coordinated. So how can we talk about that without sharing confidential information? We're not making the decision for each other. The state authorities and approval criteria are really distinct, but we can still talk. What are you asking for? What questions are you looking at? What kind of analysis are you doing? What are you learning? How can we share? Our team is also trying to figure out how we can do that same coordination with the FTC. So I think there's a lot of opportunity for that exploratory space, because right now our team is reviewing the Kroger-Albertsons transaction, which has a huge footprint in Washington state. They're two of the largest pharmacy providers in Oregon, which is why we're reviewing. But if your bill that passed last night was in effect, you would be reviewing this for healthcare too, probably. And so how do we share information on what we're looking at and our findings as we move forward? And I think we're going to keep building out those relationships as more and more states stand up their market review programs. And I'm really excited about those opportunities.
Thank you all so much for this. You guys are just a wealth of information and inspiration to keep us moving forward. We have to move on to lunch and a bit of a break, because I know these guys need a bio break. We won't stop working with you guys at the national scene, and I look forward to other opportunities where we can get our boards together on the West Coast, and we love our East Coast friends as well. Board members, let's give these guys a round of applause. You're doing a really amazing work, and we are all trying to keep stride with you. We are going to take a short break of like 10 minutes or so, 10-15 minutes. We're going to turn off the Zoom camera just to give the screens a break, and we're going to resume at 12:20, I believe. 12:30
now. We'll pick up at 12:30.
12:30. Bathrooms are out here, board members, and lunch pickup is in the other room, and we'll pick up lunch and come back in.
Is that Lauren Zeichkin's twin or?
When you're ready, we're ready. We're gonna chew and talk.
We'll choose somebody else to talk.
Yeah.
Yeah.
Leading on that screen.
So. I don't blame her.
We're ready. One of the many boxes.
We are ready to go. All right. Thank you, to those of you in the room. I hope you got some nourishment. Please, as you need to use the restrooms, get up and go, but we are going to kind of change up our agenda ever so slightly. We've asked Evan Klein, who is our, I call him our ledge guy. He is, our policy and legislative affairs.
Should I say what the legislature goes?
Oh.
Wonderful.
That's right.
Father of two, great person. Evan, it would be awesome if you would just give us an update on this legislative session. I know Jane is gonna add
At the end.
at the end of your presentation, she's gonna augment a little bit about some of the areas she's covering. So over to you, and I think we have about 15-20 minutes. Is that right? A little more? And then we will get into our discussion.
Great. Yeah, and just cut me off when you need to, and I know Michelle's gonna provide some color commentary. I think, are we waiting for the Zoom or are we good to go?
It's good to go. It's actually running. We're just having a problem with that.
Wonderful. So thank you, Sue, and for those who don't know me, I am Evan Klein. I run our legislative affairs team here at the Healthcare Authority. I've been with the agency for about 3 years and used to work for the state Senate and also for the Health Benefit Exchange after that. So have a little bit of experience kind of across the delivery system, but have been excited to work on Medicaid policy and our commercial insurance here at HCA. So wanted to give you just a quick update on some of the work that the legislature is doing this session. I'm sure many of you are closely in tune with some of the bills that have been moving in budget discussions, but happy to give you a little bit of a deeper dive. And if you have any questions throughout, stop me, let me know. If not, you can get my contact information pretty easily. So I just want to touch on, I think in the space of healthcare, the board's work, the 4 major themes that the legislature is focused on this year. They tend to be focused on some of this work every year, but certainly the case this session, and that's cost control bills, incentive structures that exist in the healthcare delivery system, coverage expansion, and then access challenges and their relation to payment. So, particularly thinking about rates, which has been a focal area of the legislature for the past couple of years. So I'll just touch on a couple of bills and then maybe a couple of items that we expect to see in the budgets when they roll out from the House and Senate in the next couple of weeks, and also reflecting the fact we have a governor's budget to kind of create the base for that work as well. But I might just start by saying there is a bill that directly impacts the cost board that is moving. It just moved off the House floor earlier this week. It's House Bill 1508, sponsored by Representative Macri. She's been really closely involved with this work for a number of years. This bill has changed shape a bit from where it was last session. It was actually introduced the first year of this biennium and has been revisited now this session. It is a bill that started looking at increasing enforcement authority for the cost board and has been pared back a good bit, but still looks at some changes to the structure of your advisory committees, as well as some of the surveillance and analysis that you can do. So I'm going to turn it to Michelle to talk a little bit more detail about the bill, and I can back there if that works.
So as Evan noted, the bill was introduced last year and we had discussions around that. It was introduced from largely the consumer groups working with Representative Macri with their interest in giving the board more tools to manage affordability. And so they introduced the penalties and performance improvement plans that you just heard about from David from Massachusetts, for example, and the Oregon model. So they had inserted that concept into the bill last year. Those were stripped out in the amendments this week. So it would not add those extra enforcement opportunities for the board at this point. It really focuses on some streamlining, as Evan noted, through the
provider carrier committee, adding consumers, labor, and employers potentially to that committee. So broadening some perspective in that group. It does have a couple of technical differences on how we would deal with the data, so that will come back to the data committee. One item in particular that I think will impact how we look at your work plan for the year would change the legislative report that's due in August out to December. So that would give the board more time to consider these policy discussions. One of the elements with the December report would be that we add the public hearing states just mentioned around the benchmark changes in experience from the carriers and the large providers that we would be measuring. So we would be expected to have a public hearing in the fall when we have that updated experience next fall, which was always one, but more called out that we will put that you will have those entities on the hot seat to talk about them. Those are the main pieces of the bill that are still in play. It does have a hearing scheduled next week, Thursday the 15th, I think. Yep. So we expect that will continue to move through the Senate at this point. So, like, oh, it has additional responsibility for monitoring uninsured.
There's a survey around underinsurance that will be required on an annual basis and something that would be incorporated in your annual board report. And then there's also some interest in continuing to look at tax preferences of entities that are existing in the healthcare delivery system. So we know that that's some potential kind of right of work that we might see coming through the budget as well. So
fine tuning on additional components we can look at the hospital. But the best and observe some of the fine tuning elements that are available.
And I'll note, through the process, thank you, Michelle. Through the process, there's been a lot of conversation about the board's benchmark and how that benchmark gets calculated. There was a lot of negotiation back and forth taking place with provider groups, which others on kind of the structure of the benchmark. A lot of that language got pulled back and pulled out of the bill when it got amended to pull out the fines and performance plans as well. But we recognize that those are conversations that aren't going to go away, and we would expect that efforts are going to kind of engage in those in future sessions. But the bill has a hearing in the Senate on Thursday in Senate Healthcare, and we do expect that it is likely to move this session. So can't prognosticate too much, but we'll keep an eye on that.
When's the cutoff? Is that their last day of hearings?
Their last day is the following Monday or Tuesday.
Can I just ask, did something get amended about medical debt monitoring or something to that effect? Or a separate bill?
Yep. So a couple other bills just kind of in the broader affordability space that I wanted to just reference for you all. 5241, kind of called the Keep Our Care Act around mergers and acquisitions. You can see just moved off the Senate floor yesterday after I think 2.5, 3 hours of debate. That bill would look at a stronger regulatory structure over mergers and acquisitions focused on cost and access, particularly access to reproductive services and gender-affirming care in the state. It's a bit of a different structure than the one you just heard about from Oregon, where they have kind of that collaborative model with their cost board and their cost growth measures. This would house mergers and acquisitions oversight at our Attorney General's office in Washington, but something that we're monitoring and certainly would expect to have some impacts in this space and a policy that we've kind of worked around the edges on. Also, 5213 is a bill looking at regulation of pharmacy benefit managers. Is kind of another cost growth tool and cost control tool that the legislature is looking at in the pharmacy space, thinking about taking some of the policies that we actually have implemented for our state purchase programs for Medicaid and UNP that prohibit spread pricing by PBMs and implementing that across the commercial insurance market. Other little things in there around community pharmacies and payment and receipt of pharmaceuticals from different types of pharmacies But I think the big policy there, especially for you all's interest, would be the prohibition on spread pricing. So we've been working closely with legislators on that bill. We have yet to see it get pulled for a vote on the Senate floor. Oh, it is, okay.
Yeah, it just hasn't shown up on order.
Shown up on order, yeah. So possibly in the next couple of days, we should know, by next Monday or Tuesday, that bill is gonna continue to move. 2066, this was around anti-competitive contracting. This bill did not make it out. It's not going to make it out of the House this session, did not make it out of the House Healthcare Committee, but did have a hearing. It was a bill that we at HCA were supportive of, but was looking at contracting practices from providers that was likely, that exist in the market and are likely driving some costs by requiring, if there's a hospital that you need in network as a health plan, if that hospital wants today, it can put contract clauses in its contract to require any other affiliated providers to be part of that network as well as part of negotiations, kind of take it or leave it arrangements. So the bill was seeking to prohibit some of those contractual terms in the state. As an advance, we expect that will be a conversation in future years as well. Other bills that kind of floating around the cost space, bills that were looking at consumer cost sharing for specific drugs and services. So there's a bill that's still moving 1979 on inhalers and epinephrine auto injectors and looking at controlling the actual copays that an individual would pay for those. We're generally supportive. They're concepts that, again, we tend to implement today in our state purchase programs, including UNP, but would help mitigate kind of direct out-of-pocket costs for consumers. Bill on facility fees and a bill on ambulance balance billing, which I'll let Jane speak a little bit more to here in a second, and a couple of other policies in the cost space that we expect moving. So before I turn it over, I'll also touch on a lot of what happens with investments in the system tend to come through the budget. And so we are waiting to see what the legislature proposes this session, but we know there's continued emphasis on provider reimbursement rates. So I think it is important to think about as you're doing your work to control costs in the state or think about how we can manage our costs, that there are certainly aspects of the delivery system where we're looking at further investments. And in the Medicaid space particularly, we know that there are access challenges largely around, primary care, behavioral health, maternity services. And so we and the legislature have been partnering over the past couple of years to seek investments in that space. We expect that the legislature may take some further action this session, particularly around behavioral health rates. So for residential treatment, SUD, community behavioral health, thinking about how we can continue to sustain and grow that workforce and doing so through adequate payment in the Medicaid system. And we know that that's an issue for commercial insurance as well. So that's a bit of that tug and pull, that tension. We know that there are investments needed in some areas of the delivery system. At the same time, we're trying to control costs. Also, coverage expansions. The main one I want to call out for you is that we're still kind of in the throes of implementation for our Apple Health expansion program. This was funded by the legislature over the past two sessions to stand up and expand a kind of Medicaid lookalike program for immigrants in the state who currently cannot enroll in Medicaid or were previously unable to get subsidies on the exchange, although through their waiver that has changed over the past couple of months, which is great. But this is really a partnership with the exchange's work on their 1332 waiver and thinking about how we create the same continuum of coverage for individuals who lack those federal supports at the state level. So that is something that's set to go live July 1st. We are looking for the legislature to invest a little bit further in some of the administration of that program. We got some funding proposed in the governor's budget. We're hopeful that the legislature will pick up some of that as well. And then we know that there will be future conversations over the next couple of years around expansion of that program. It wasn't fully funded in the first go round. We got around $47.5 million for the program. We expect that will not allow for everyone who would technically be eligible to enroll. So I think there's going to be, additional work with the legislature and with our authorizing environment to think about how does the program kind of expand after we go live this July. I might pause and see if there's any questions, and then I can hand it over to Jane, who's going to touch on, I think, balance billing and maybe one or two other bills as well.
Lois, I read 1508 to remove the authority to require reporting and collection of data. That seems like it weakens the position. Why? Any thoughts on why they're doing that, or how we will still be able to get all the data we need?
I think so. In the bill, and particularly in the effects statement of the striking amendment, it speaks to a removal of some data collection provisions. What I think that that's speaking to, though, is more in the the previous version of the bill, there was some increase in data collection that had been proposed that got struck out of the amendment that moved off of the House floor. So I don't believe we read the bill as impacting the status quo. Your ability to work with health carriers on the benchmark data call on an annual basis, for example. It also includes some provisions that allow for data sharing within the agency, which would allow us, for example, to make sure that you have access to some of the data that our Prescription Drug Affordability Board has access to. So I think, yeah, so hopefully, and our read at the agency level is that it should not undermine any of your existing.
But we don't have any increased powers to sanction or create penalties for those that were difficult this year. As you know, I reported out some challenges we had getting data. Didn't get any gains there, and we'll be back at that because we really need data submissions being timely and accurate and people to participate.
Okay, so just a few things. Over the past 5 years, our legislature has incrementally prohibited by law balance billing, which is your insurance company pays an out-of-network provider, your out-of-network provider decides that's not enough, and then they send a balance bill to consumers. So it's illegal to do that for air ambulance services, for emergency room services, when there's an out-of-network provider in an in-network hospital. Where it's still legal is ground ambulance services. So we regularly get complaints from consumers who are getting like $500 bills, $1,000 bills for balance bills for ground ambulance. So the legislature directed OIC to work with folks over the year, last year, come up with a bill. There is a bill that passed the Senate unanimously yesterday. So now it's over in the House. We think that it's got really good bipartisan support, and no surprise, what's the biggest issue? The biggest issue is what rate the ground ambulance, the out-of-network ground ambulance provider should be paid. So that's the one issue that'll be getting more discussion, I think. There's also a bill that passed the House yesterday and is over in the Senate. Some of you may have heard a lot about a federal district court decision called Braidwood that would have really weakened the preventive services that have to be covered with no cost sharing under the Affordable Care Act. And several years ago, the legislature passed a law to embed those federal preventive services protections in state law, but it's now outdated. So this bill sort of updates it and makes sure nobody's going to lose access to preventive services. And then there are a couple of bills that are out there related to substance use disorder treatment, particularly residential treatment, about concerns about people who think they need more treatment and getting kicked out, or their insurance company saying, no, we're not going to cover any more treatment. So there's a bunch of discussion about that, especially given the fentanyl crisis and opioid addiction and the horrendous rates of that in the state. And then the only other, probably two budget issues that we're looking for are the legislature sort of jiggling around some of our money so that we have more money for the actuarial analysis and the deeper dive on the policy options that I described earlier in the preliminary report. And finally, our office has been engaged in a lot of work around mental health parity compliance. And we've been funding that work with federal funding. And so we've asked the legislature to give us funding so that we can make sure we can continue that work. Is a classic example of where states need to work together. Because you've got national insurers that have the same policies with respect to coverage of mental health services. And so coordination across states is really important on that one as well, sort of like what Sarah was saying about why. So that's what's going on. Those are the big things we're looking at. And then, of course, the PBM bill that Evan mentioned and the Keep Our Care Act bill. Probably one of the most notable things about the Keep Our Care Act bill is that as originally drafted, it would have only applied to oversight of provider acquisitions and mergers. And there was an amendment that was adopted on the Senate floor last night to also apply to acquisitions by health insurers and their holding companies per our discussion earlier today.
Thank you for that. And I think, Ingrid, you've got some breaking news.
Hot off the press, the legislation to further standardize the exchange market passed the House, I think about 5 or 10 minutes ago. I don't know, 58 to 39. So this is relevant for this board. Sorry. Hey, everybody. This is relevant to this board because it is a way of addressing, creating greater affordability. Because thanks to the pioneers of this concept, one of them is sitting at this table. Standard plans allow for more care before the deductible. They have lower deductibles on average. And this last open enrollment, our analysis shows that standard plans were $75 less in premium overall than non-standard plans. And they also help people avoid hidden costs. So when there's complex cost sharing arrangements that have things like co-insurance and people don't understand that, then their total cost of care, even if the premium looks lower, their total cost of care can be higher in the end. So this bill will fully standardize it at the silver medal level, and we'll get more details to you later, but it's a step in the right direction. We'll see where it goes from here on the Senate side. Well, it happened like
We
5
just
minutes
have
ago.
5 minutes
It happened
ago.
when you were talking.
It's popped up, so we thought, wow, let's hear more news. And I think to just amplify that a little bit, I think the more we can create uniformity or the thought about, 10 years from now, there's just so much complexity, the way things are contracted, the benefit designs, the deductibles, copays. And the more we can continue to just advocate what is good. I know several of you here at the table have some very, as well as the state, have just some very standard-like plans that really minimize the burden. And I think when we hear at our next meeting from Noam Levy on debt, medical debt, I think it's just continues to be incumbent on us to watch that, those hidden prices that crop up somewhere else and understand all that measurement. So anyways, that's great news. Thank you, Evan and Jane, for that, and Michelle for that information. I think with that, we're going to pivot back to kind of our regular agenda. So thanks, Evan. We know you're back over on the hill. And I am getting texts that we really need to amplify. So if it seems like I'm shouting across the room, it's really because I think those on the phone are just asking us to speak up. I am going to ask now Liz and Gary, they're going to help us facilitate our conversation about reflections on the presentation that we just heard from our other states and just all that we've been digesting all morning. So Liz and Gary, over to you to help us.
Gary, are you presenter mode now? Just wondering.
I'm here.
Oh, okay. I'm waiting for the Golden Gate Bridge to show up again. Okay, so thank you all, and it was so exciting to hear what's happening in the session and some of the progress that's getting made. So as Sue mentioned, Gary and I are going to help help all of you kind of think about these different policy options that we've heard about, some of which we've heard about from Jane, we heard about from the other states this morning. Really just try to understand what the landscape is and help this group sort of pivot to, okay, we're getting the data, we've got all this information. What can we start doing about this? Because there is a lot being done, But I will say, you know, as the presenters from the other states said, Washington is out front. It's always hard to be the lead sled dog, but does really important work. And I think there's a lot of opportunity, I think. And as Michelle and Evan, Jane and Ingrid shared, where progress is getting made slowly but surely. So besides talking about can we go to the next slide? Besides giving a landscape, our goal today is to winnow down from this landscape that we're going to share with you to ideally the top 5 policies that you would like to spend your time on over the course of 2024 to develop some recommendations to the legislature. So that is our hope. And you have a handout in front of you, Gary. I gave them the handout that has the map and all the colors, the different policies, just to sort of give you a picture. If we can go to the next slide too. There's 2 pictures, the one that's in front of you, and then this one that's on the board here. And this is our attempt, so HMA's attempt, along with support from HCA staff, to really map out the different policies that we're talking about and what they could mean in terms of addressing cost and affordability in some cases for consumers, and kind of graphing it against how complex and what the impact might be. So the one that has the handout in front of you kind of gets a little bit more into the details, but this is just a quick snapshot of the different things we're going to be talking about. And we'll come back to it at the end after we go through all of them. Okay, next slide. So we've grouped these in a few buckets. They're short term, short to medium term. There'll be medium term and long term options. And Gary and I are going to go back and forth. We're going to really just try to provide a flavor to you about what these options are. Not go into a lot of the details, but give you just a taste and talk about potential impacts, complexity, so that at the end we can circle back and say, okay, I've heard a little bit of all of these. Here's where I really want to go back and spend our time this year. So, okay, let's go to the first slide. Next slide. I'm not going to talk about this one because I think we talked about it earlier, limiting facility fees. I don't know, I'll just pause. Does anybody have questions about this one?
Is there any idea of how much these fees are as a percentage of costs annually?
Jane, I'm Gary. I'm just trying to think about the report that we did, the affordability report. We do go into detail on the amounts in there. We have some information from TOH, I believe. In the
Yeah,
report.
there's reporting to I'm sorry, these is a chocolate.
Sorry.
There is reporting to the Department of Health. I can share the website where hospitals are supposed to report sort of the average, the range of the facility fees they charge, total revenue they gain each year from facility fees. But the reporting is pretty spotty. We'll have one year that a hospital shows up and the same hospital doesn't show up the next year. The challenge is for commercial health plans. We can't see that data in the all payer claims database. It doesn't show up as a separate fee, so it's challenging.
Wild.
I don't have one off the top of my head.
Okay.
Center for Health Insurance Reform.
Yeah,
They just did a big report on facility fees.
Gary.
And I can't remember what data they shared, but that might be a
Yeah.
good resource to send out.
I do know this one. I mean, this, in terms of putting the report together for OIC, this was very difficult data for us to get. It's very challenging. So I think that's one issue is the data. We don't have a lot of it. And some of the recommendations from that report were focused on, we need more data on this. I do know that Medicare is also looking at this because it's happening for Medicare patients as well.
And Congress.
So, but again, I think, Gary, I'm just looking at you because you're probably in front of your computer and can pull it up, but it's the CHIR report, I think hundreds of millions of dollars. It's a lot of money that people are gonna
It's a
get
lot of
impacted
money.
by.
It's just hard to figure out
Hard to
exactly
track
how
it.
much it is in Washington.
But I think this, oh, go ahead.
Just chair's prerogative. I know we have 3 experts back there, and I'm just curious if you all have any gut sense beyond hundreds of millions or how you would flesh that out. And Drew, Drew, I'm kind of calling, doing a phone line to, I was just saying on facility fees, if the Alliance and or any of the others of you have been kind of estimated the magnitude. If we were to move forward with limiting facility fees, if you all have been already starting to size that from a data gathering and or an analysis, and if there's any speculation you might have, because the question from our board member was, well, what kind of money do you think that would save us?
So I would say we'll start looking at that. We haven't been allowed to look at that because there are members of our board that didn't let us look at our data. Paid for those might be. And last summer, we were able to get a memorandum that they didn't respond to that says, we're gonna look, we're not gonna publicly report it, but we're gonna start looking. So since we hire a data analyst, because we're a little small, and we have a grant right now looking at sort of hospital pricing. Facility fees are clearly a big chunk of that. And it's an increasing chunk. It used to be a couple facilities did it with Medicare only. Now they're applying it to everybody. It impacts access to care, it impacts equity. You just imagine you're going for, a therapist visit for behavioral health. Now you get a $500 bill on top of that. That's not okay, especially when you thought you were just going.
And the big challenge with that is, this is gonna get geeky. For Medicare and Medicaid, if I'm that therapist that works in that hospital or clinic, I'm gonna submit two claims. I'm gonna submit a professional claim for my service as a therapist, and then the hospital is gonna submit a facility claim for the facility fee. When we went in and we looked at the commercial health plans, there's not that bifurcation of the billing. It's just one payment. And so it's really hard to tell what chunk of that payment is for the therapist and what chunk of it would go to the hospital. Because in a lot of those cases, the hospitals are doing the billing for the therapist and they call it a hospital outpatient department visit.
Well, and I'll just throw in, the last time we did any legislation on this was the problem in Yakima. Yeah. And a hospital bought the doctor's clinic and, people had been going there and never having a facility fee as soon as they bought it, even though the building, they were buying practice and the building. It had been paid for by the doctors when they were building. Well, then the facility fee just gets tacked on. So even it's, and as we've seen this vertical integration, you're seeing more and more facility fees on, the idea of a facility fees to pay for the capital side. I mean, kind of.
Well, theoretically, the idea behind a facility fee is that hospitals are required to have their emergency departments open 24/7. And so, and Drew chimed in here, and so they need to recover those additional costs. But the question is, given the degree of hospital acquisition of provider practices, whether those facility fees are truly just covering those costs or whether they're an opportunity for additional revenue. That's the question. Okay.
Great.
That.
Yeah, it's all part of the revenue cycle generation.
Yeah.
Component. So how do we extract more money out of the health system? That's $1 trillion a year cost out of the $4 trillion for health. Is pulling money out of the system or preventing money from coming out of the system. Health plan trying to do the opposite, right? None of that improves care. Right? You still got care.
So just looking quickly at a report from the Healthcare Cost Institute, which is collects a lot of data on healthcare costs. They cite a figure that having site neutral payments, where the payment would be the same regardless of where it takes place, could save $450 billion over the next decade, including $380 billion in premiums and $70 billion in cost sharing. So that's one estimate that's out there anyway.
A lot.
That's nationally over 10 years.
It's a lot, and I think
I just want to point out, and Michelle jump in here, but there was legislation around this again, and it sounds like it's come up multiple times and it doesn't go anywhere, unfortunately. So this is an issue that getting attention could probably, you know, benefit from more attention, more data. And I think as folks have talked about, this is not so much that it would impact costs, it's more of a consumer issue. I have personally gotten many of these bills like this where all of a sudden I have hundreds of dollars in the hospital bill and it's like, I just went to get a lab draw or something like that. So it's a surprise bill for a lot of folks. So I think that's how I think about it. It's a surprise bill. You don't know.
I think we have one more expert comment back here and then we'll move on. Go ahead.
Just real quick, from a policy perspective as to what to do about the facility. I think looking at them as a monolith is probably going to be very difficult. There are legitimate fees around the hospital infrastructure, infrastructure for the hospital imaging department. And then there are the example that I really did. Clinics that are really not connected physically to the hospital building. However, they're becoming more of a revenue source, an overhead source. So a more tailored approach to facility fees makes sense from a policy perspective. But just so folks know, even though the proportion of the facility fee for that total clinic bill is high, that total bill itself is not high enough to make enough dent in the total healthcare expenditure. So while that proportion may feel like, oh my God, it was supposed to be $1,000 bill, now it's $1,500. Yeah, that proportion is high. But compared to the $15,000 hospital bill, that means nothing. So just keep that.
Okay, let's go to the next policy. Services not covered by the Balanced Billing Protection Act. We talked about this one pretty extensively, and there's been a lot of work happening in the state to address this. We can go to the next slide. Again, low impact on underlying costs, but a significant impact for consumers. And it sounds like things are going to get addressed this year in terms of the holes that are still left in that bill here in the state. Thank you, Jane, and everybody. Okay. Next policy, restricting anti-competitive contracting practices. We've heard a lot about this morning from some of the other presenters and from Evan. This is, this is allowed. Right now, the OIC report and the AG office go into this a lot. This is allowing dominant providers to raise prices through anti-competitive health plan contracting, in which provider groups and health systems utilize their market power to demand terms in their contracts with health insurance plans. And with the amount of consolidation that's been happening, this is happening more and more often. So if we want to go to the next slide. Doing something around anti-competitive contracting practices could have a significant impact on controlling healthcare spending and increases. We don't think the complexity of doing this is that high, and it's more of a short-term, something that we could do in the short term. This was, as we discussed, covered in the AG's report, and there's legislation going on with this right now. But diet, yeah. Yes.
For the third year in a row.
Yes. So this is something to think about. Great. Okay, and increase hospital price transparency. So this is a lot of the work that you all are doing here as the cost board. And allowing more transparency to consumers, but we know that the price transparency, the use of those websites and information remains low. Go to the next slide. We think this is a medium impact to addressing costs and a medium impact for consumers. Not very complex to implement and a short to medium term timeline on this one. Again, it's not clear how many hospitals are complying with this, and CMS is currently updating enforcement around this. Any questions?
Do you know whether CMS is going to change like the format if the hospitals do it, I've done some research looking at these, it's not a program that the normal person even
Even
has.
uses. Yeah, my understanding is that they're in the process of updating that. Next, Gary nodding.
That's been a real, you're put your finger on a real significant issue, which is that the format that the reports are in now is not readable by somebody who's just interested in going and looking. So that I think that's something that CMS is looking at now.
I think another issue too is, so what happens is like there's a company called Turquoise. And they go into those machine readable stuff, they digest it, and so they'll sell to people their service of being able to translate.
Hardly
machine
transparent.
Yeah, and one of the issues that comes up with price transparency is the theory behind it on price transparency is that people will see what their competitors are charging and lower their prices to meet their competitor's price. But what has been happening in some cases is that competitors will look across, see which of their competitor is getting paid the most, and then will go into negotiations with payers and say they want to be paid what the highest paid competitor is being paid for the service. So, or what the other payer that's paying for that service. In theory, good theory, but sometimes there are unintended results.
Well, and for consumers, I mean, you're in an emergency, you have to have an emergency surgery next week, or you spend a lot of time looking. So it's just the reality of how it is for people. Okay,
So can we summarize what, that was a good discussion of the general topic, but what, there an articulation of what this book proposes? To take transparency that's
The next level.
unintelligible, to the next level.
The next level.
Like, I think Liz, you were trying to go through all of them and then to make sure everybody has level set. on
Okay,
these
just
topics.
background, okay.
Yeah,
I was
and then I think we're gonna move to,
Discussion, but if you have a comment, you should make it.
No, I just wanted a little more clarity, other than the general topic, but we'll get back to it.
Okay. All right. So the next policy that we have on the landscape is community benefit transparency. So as you all probably know, nonprofit hospitals get an exemption from paying taxes and they can issue bonds. There's been a growing concern that some nonprofit health systems are, claiming this exemption, but they're reducing staff, demanding payment from patients who qualify for charity care. And so this is just an issue that is really starting to get a lot more attention. And so we have this on as a possible area to study. Just want to go to the next slide. Medium impact on consumers, again, does not address the underlying healthcare costs. Would be relatively easy to implement and a short to medium term solution. But again, we want to just be really clear about the policies that we think are impacting healthcare costs and ones that are more focused on consumers and payers. So sometimes you'll see those notes in the slides. Okay, so now we're going to go to the medium term options, and I'm going to hand it over to Gary to lead us through most of these, and then we'll go back and forth.
Okay, thank you. So we've talked a bit about mergers and acquisitions and consolidation already. And the research is pretty strong that when you have a consolidation, whether it be among providers or whether it be among payers, insurers, etc., and that whether it's horizontal consolidation or vertical integration of different services under a holding company structure, the tendency is to have higher prices and increase cost. And with the best research is mixed to negative impacts on quality. This is a very challenging issue because I don't think anybody thinks it's going to be possible to unwind the extent of consolidation and integration that's already happened. But you heard from Sarah in Oregon in particular, and also from David in Massachusetts that you know, some states have done more on this to regulate this and review transactions than Washington has. Next slide. This is a one distinction that I want you to bear in mind as we go through all of these policies is the distinction between policies that directly impact price or cost and policies that indirectly impact them. So for example, if you regulate anti-competitive clauses in provider contracting, you're not looking at the actual costs or the prices that are being charged, but you're doing something that you hope will increase payer leverage in negotiation, and that will lead to more affordable prices. So it's more of an indirect approach than a direct approach. Some of these that I'll be talking about are actually direct limitations on the prices that can be charged. And that's a different kind of regulation. Obviously, it's controversial and can be very complicated technically. So I want you to, you know, sort of keep that distinction in mind as we go through all these. So limiting out-of-network charges, you know, this kind of goes along with the balanced billing and surprise medical bill issue. And the policy would be to put a cap on what can be charged when a service is provided, for example, by a hospital out of network. And a number of states have adopted policies like these. In some cases, as in California, what happens is if an agreement can't be reached on what the out-of-network charge should be, there's arbitration. And another approach would just be to say, you can't charge more than X% above the network charge. I mean, you know, so there are different ways of approaching it, but that is generally the policy that's being discussed here. Next slide, please. So this is what we would call a medium term. You know, it's not as complicated as some of the other ones I'm going to get to in a minute, but would have a significant impact on consumers who are faced with these out-of-network charges. Next slide, please. So Jane talked about the issue having to do with rate review, providing authority to for the Office of the Insurance Commissioner to review large employer rates, which it currently does not have, and which Rhode Island has done. And then there also could be some additional specific authority given that would strengthen the standard that the Office of the Insurance Commissioner applies as to whether rates can be used or not, which right now the standard is, are the rates reasonable? And some states have done a little bit more to kind of make more specific and provide additional authority on that as well. Thank you. So again, this is, you know, what we're characterizing as a medium term and medium impact type of policy. Next slide, please. So administrative simplification, this is an issue that the Office of the Commission of Universal Healthcare Commission, sorry, I'm stumbling over the different agencies, is going to be spending quite a bit of time looking at this year. The idea being that there are administrative costs in the system, largely due to how fragmented the system we have is, with, you know, so many different payers, so many different providers, and that those costs make up a significant portion of total healthcare costs. We heard a really great presentation on a paper that had been written recently in the Journal of the American Medical Association that lays out a number of different policies that could be implemented to reduce administrative costs without any impact at all on quality of care or access to care. So this is, you know, this is an area that's very ripe for policies that could definitely impact costs. And as I said, the Healthcare Commission is going to be doing a lot of work on that this year. Next slide, please. So Jane talked about this as well. Yeah, there's a lot of discussion right now around pharmacy costs in general, but in particular about the practices of pharmacy benefit managers who are able to achieve lower pricing, and those lower prices are taken as profit by the PBMs rather than being passed along to consumers. And there's proposed legislation around this at both at the federal level and at various state levels as well. Next slide, please. So again, this is one that could have a significant impact on cost for employers and purchasers if this could be accomplished. Next slide, please. Private equity, we've talked a lot about. Again, this is, I think the first step here, as we've discussed already today, is to get more information on what is actually happening. It's very hard to know the extent of private equity purchasing and ownership and what the impacts have been. And it's hard to understand exactly what could be done to affect that, but at least as an initial step, it seems very important to get a better handle on, what's actually happening out there. Next slide, please. Okay, so moving on to longer term, and when we say longer term, what we mean is these policies tend to be much more complex technically, politically as well, frankly. And this is the group of policies that really, a number of them go directly at looking at either rates that are set by insurers or prices that are charged by providers to get directly at trying to impact the cost of healthcare. Next slide, please. So Maryland has been very much the leader in some of this. They put in a system where hospital rates are the same for all payers in the state. This was done through a Medicare waiver a number of years ago. And so the idea is rather than having individual negotiations by each payer as to what the rate should be that hospitals are charging, there's one set of rates that are established through an administrative process by the state. They've recently expanded this to also include primary and specialty care providers. And there's two aspects to this. One is, as I indicated before, just the simplicity of not having to negotiate multiple contracts with multiple payers reduces the cost and administrative burden. And then obviously, depending on where the rates are set, you can see significant cost savings as a result of this. And the experience in Maryland through their Medicaid waiver was they have been able to show reduced costs in the Medicare program through this type of policy. Next slide, please. So this is, high impact, but complex and difficult to accomplish. It's discussed in the preliminary report that Jane talked about earlier today that we helped put together. So it's one, again, direct rate setting type of policy that some states have utilized. Similar type of policy, rather than rate setting or saying, well, this is how much you can charge for a particular service. This just regulates how much the growth there can be in the price of services. It's analogous to what you all are doing with your cost benchmarks, but it's at a more specific level. So you're not actually setting prices, but you're saying, okay, primary care rates should only go up by X% a year, specialty services by Y%. And you can do that by looking at cost drivers. What are the costs that are increasing the most and having the biggest impact on total healthcare costs? And you can also do it by looking at which are the most common services that are used by the most people, so that if you can control costs in those particular areas, you're going to have a big impact. So primary care being, obviously one example of doing it that way. And you're still permitting prices to vary underneath the cap. So this is less intrusive than some of the policies I'll talk about in a second. But nevertheless can be an effective way of at least mitigating growth in healthcare costs. So again, high impact, but complex and a longer term type of activity. Next slide, please. So global budgeting is again something that Maryland has kind of been a pioneer in. The idea here is you tell each healthcare system, hospital system, we're going to give you a budget for the services that you're going to provide for your patient population in a year. And it's up to you to figure out how to live within that budget and provide the services that you need to provide to that population. So in some ways, it's less intrusive in the sense that we're not telling you how to do it. We're not telling you how much to charge, for an MRI or what have you. But we're giving you an overall budget and telling you, you need to live within that budget. Obviously, setting those budgets is complex, but they tend to be built on the existing budgets that the hospitals have been working under, and they can be adjusted for utilization, population, and so forth. So, but the idea is that once the providers know what their budget is, that gives them an incentive to be efficient, to live within that budget, but it is definitely shifting financial risk to the provider. And as we heard a little bit ago, that is something that providers may or may not be, very happy to take on. But that's the concept of global budgeting. And again, potentially significant impact, but highly complex and difficult to put into place. Next slide, please. So reference-based pricing is another tool. And the idea here is, we look at what prices are in the commercial market compared to what Medicare pays. And typically, the prices in the commercial market tend to be at least 2 times as high, sometimes even more than that, as high as what Medicare pays. And so the goal here would be to set a reference point to say, okay, prices in the commercial market should be no more than 160% of Medicare or 140% of Medicare or 180% of Medicare, whatever that number might be. The Cascade Care Select, the public option in the exchange, already does this by setting an overall price cap of 160% of Medicare in those plans. And so there is some precedent to doing that in Washington. It's also been done in some other states, Montana, and I'm blanking on the other one, in their public employee program. So this is a policy that could be phased in to see how it's functioning and how it works. And again, the goal being here to try to limit prices, but by using a reference point that already exists. So you're not starting from scratch. You're not saying we need to figure out how much an MRI should be, but we're saying here's what Medicare pays for an MRI, and we think that employers and individuals should not be paying, should only be paying a certain percentage above what that Medicare price is. So again, significant impact, I would say, compared to some of these others, a little bit easier to do because you're working from an already existing price level that's set by the Medicare program. And again, this is one where it's talked about in the OIC report. And then this last one that I'll cover, it has to do with state purchasing. So the state already has obviously a significant role in as a payer in the public employee program and the teachers program. And the question is, can that be can the state get more leverage by expanding the number of lives that it is procuring on behalf of to give it better negotiating power vis-a-vis the providers? So, you know, as you know, right now, for example, in the Medicaid program, it's largely done through commercial Medicaid managed care organizations that are doing the negotiating. But, you know, one type of policy that's been discussed is to give the state more of that purchasing power. Another example that's happened in California is the state decided to take over negotiation over prescription drugs. So the managed care organizations are no longer responsible for that negotiation. The state is going to do it. The goal being, again, to use the purchasing power of a large pool of people to be able to negotiate better prices. Remains to be seen how well that's going to work, but that's the theory behind it. Okay, and I think that, Liz, I think that covers mine.
That's it. Oh, that's all the policy options.
Oh, okay. We did it.
Did it. So just a couple of questions / comments. I want to ask you, open it up for questions, but you know, as you've seen, we have 4 categories about how we, you know, try to classify things. Are there other factors that you all think should be considered as you are trying to prioritize? We talked about complexity. We talked about the impact, how long it would take, who it's gonna affect to some extent. So what, is there anything else?
Liz, I would add a criteria of looking at in which of these does this board have a unique role or value add based on the function and direction of what this board is set up to do, what data we have available, et cetera, versus where we have other types of entities like this one already taking lead on something.
Yeah.
And we, okay.
I would echo that, because I think, again, if we know, you know, that IHME, for example, or the Alliance, or PBGH, or OIC, excuse me, I was just gonna say Jane. OIC, or the AG's office are clearly doing work that we can echo or support or point to on our report, but not do redundant work. So totally agree with that. So as we go through these, I would just want to be very clear, like global budgets, I believe James already got, OIC's got
The
some
evaluation.
Yes, and we did try to do that, but I think it would be good actually, because we have some other folks in the room and you all may be aware of other initiatives that are going on, to go through and make sure we've captured that so that it's reflected, because it may not be on this little thing. So we talked a little bit about, you know, as Gary mentioned, the commission is going to be looking at administrative simplification. Jane, you're looking at global budgeting.
And you mean the Universal Health Commission on
Yes.
Administrative, so
Yes.
they'll have
Yes.
big recommendations there about.
Yes. I anticipated after the conversation that they had last
Yes.
week, so.
So I see a distinction. There's a distinction of who's like on point to actually implement kind of something, who's on point or doing work to do deeper analytic work. And then is, regardless of who's doing those two, is this a policy that the commission wants to endorse, or an activity that the commission is that the 3-part kind of way to look at it?
But couldn't the board decide to endorse something that
Yes,
OS
yes.
might be working on, that's not a priority that they're gonna do a deep dive on?
Right.
So not putting it as a priority doesn't exclude the opportunity to support.
Yeah, that's what I was saying. So,
Yeah.
it's like, does this group, does this board want to put resources into doing deeper analytics? Or does
On
this board
something.
say,
Yes.
I'm happy to wait and see what X is
Oh, I
doing and
Yeah.
endorse that work?
So not putting it as a priority doesn't exclude
That's
the
right.
ability to do that.
Yeah.
Although it would be
the track. It would be helpful to track that if the board has feelings about that.
So let's go through real quickly. So universal health.
Just quick question. I appreciate the policy efforts already underway as a category, but I kind of heard murmuring throughout the conversation that there are some things that are like dead or have been tried many times. So local feasibility might be a useful thing to understand.
Well,
I mean, I kind of heard it, or maybe it's too hard to know, but having that context of like what has been tried before, what has been the track record, it might be useful.
Just because it's controversial doesn't mean we should.
No, no.
I think we should have it happen before. I think that's a really important point, that, you know, there's a role to study and recommend, and things can, one policy that you may decide to look at now or that gets endorsed could, you know, pave the way for something else over time. So I actually do think it would be helpful to go back because literally things are changing moment to moment with the legislative session going on with some of these policies and other things. So we should just kind of go back through to make sure that we've captured the work that is happening elsewhere on some of these things. So you can know whether or not, you know, if it's being handled elsewhere and you just want to get an update and endorse it, or if there's a role that the board needs to play with it.
And can I just add, even if you decide not to prioritize something, that doesn't mean you can never look at it again. It just means sort of what are we focusing on in 2024? And we all know, I mean, we're in the middle of session, things change, and we could always go, you know, this one's now taken care of. Let's go back and look at the other ones and pull something forward. So you're just sort of giving us some direction here.
And I would just add that because something not unabated this year, it's a short session, not a long session. And so it's not supposed to be a big policy session, which is a joke, but you know, but that's the theory behind it. So in next year will be a long session, so there's more opportunity to bring up some of the things that take a lot of work, you know, that.
And well, and the other thing to note is Senator Randall in her floor speech on Keep Our Care Act noted that this was the 4th year that she had been working on that bill. And Eileen can give you a speech about incremental strategies.
How do you think this board got started?
Helpful.
So I have a comment. I guess I was noticing that we're talking a lot about, it seems, 3 sort of spheres of concern about cost growth, about affordability for consumers, and about equity, about increasing advancing equity. It seems like those 3 are sort of the big themes. And so I noticed that, you know, the analysis that we're discussing right now about, you know, these options are to address costs and improve affordability. I think it's interesting that the Massachusetts report included, you know, their hope or an idea about including 2 new benchmarks in addition to the growth benchmark, an affordability benchmark, and a health equity benchmark. Now, I don't know if, you know, if that's going to happen or, you know, whatever, but it was intriguing conceptually because it creates that official formal balance, you know, that so one of those doesn't get left behind or sort of overwhelmed by the focus on the others. So I guess in response to the question on at hand here, I think that I keep thinking in my mind about options, which 5, what do I vote for? You know, I'm thinking about impact on cost growth. I'm thinking about affordability for consumers, and I'm thinking about health equity promotion. And so is there an opportunity to, you know, to consider in some formal way in this analysis that we're considering, you know, going to sanction or plan formal analysis of impacts on health equity. So it's kind of this 3, you know, the big 3. And I'm not saying it's a third. I'm not saying that, but I am, because I haven't thought about it. If it's a third, but it maybe cost growth is, you know, 50 or 60 or something, but then the other 2 get sort of formal acknowledgement and recognition in a very official way.
So go ahead, Ingrid. I just want to thank you for raising that, and just a related
point that I'm staying on over here is the issue that we had a lot of important discussion about primary care. We have a subgroup looking at primary care, but we're not looking at it in this matrix, I think, because it's in a different
Bring their own
subgroup.
policy recommendations.
Yeah, but I think it's important to also be part of this conversation, and it directly drives primary care. Yeah.
So just I mean, and I'm gonna look at HCA staff here, but I think that I think that these are excellent points. And my understanding of the process for today is that we don't have the tools to do that necessarily like at our fingertips. So I think the idea is, can we pick 5 and then maybe apply that type of analysis throughout the year? So is that what you're saying? That as
Yes.
we, winnow down?
Intend, yes, because I think I make my comment is
Yes.
to intend to know more. You know, and to seek out, you know, consciously. I'm not assuming that you'll find just what we're looking for or that we'll be able to,
We can be intentional.
but we can be, yes.
Absolutely. And I know that HCA, you guys have a win, right? Does this work? So health equity officer. Let's do it.
One other factor that I would suggest is, given that, you know, ERISA is the 800-pound gorilla in the room, is which of these options provide the greatest opportunity to partner with self-funded health plans on initiatives? Given that.
I just told him that was his role. He had to tell us.
That's what we do.
There's a couple self-funded. No, I mean, it's just, the reality is 2/3 of the people in the state that have employer-sponsored coverage are getting it through self-funded health plans. And it's a critical mass discussions. So.
And I would say the presentation that a few of us got to hear from the folks about admin simp last week really drove that home. That if we do something over in, 2/3 of the market and the other third isn't there, it's just not gonna have the impact that we want it to. So that's a really good suggestion.
So Jane, one comment I would make about that is that your ability to impact those people who are covered by those self-funded plans is greater if you're regulating providers and prices than it is if you're regulating insurers and payers. Right, because the federal law does not say that you can't regulate the prices that hospitals, for example, or medical groups charge to all of the patients that they serve without regard to what the source of their healthcare is.
But I also think it's really important to acknowledge that, and I'd love to hear from you, right? When we have discussions about where we can partner with self-funded health plans, I'll take the experience of the Balanced Billing Protection Act and what plans have opted in. It's almost always a plan whose only employees are in Washington State. Because if you, like Costco, right? I don't know how many states Costco operates in at this point, but it's just a different. So it's a different.
We're not in, no, we're in Alaska. We're big in Alaska. Rhode Island. West Virginia, Wyoming.
Really?
We just opened up.
Rhode Island, West Virginia, was third?
Wyoming.
Wyoming.
But it is just an example, right? What's the dynamic of the discussion that you have with big
Well, I mean,
purchasers like
we're
you?
administered by Aetna across the country, and they negotiate on our behalf. So, and they're having trouble like everybody else, coming to agreements with hospitals and networks, and it's ugly right now. Well, they cover Amazon and Nordstrom and around here, and other companies too. But so they're negotiating on all our behalfs, but there was a hospital up in Kirkland that did not want to agree on rates. They terminated with us for about a month and a half until they came up with an agreement. So it's just hard.
Margaret has a question.
It's true.
Yes.
Yes, I think one of the things that we should consider is whether the action is likely to increase cost shifting or whether it will reduce costs for everyone. For example, I would worry if increasing the number of political entities that the healthcare authority covers might save money for the political entities and the healthcare authority, but the providers might increase their costs to other people as a result.
I mean, that was part of what you were getting at, right? That it's important to think about what employers are going to be interested in.
Well, and also, I mean, Margaret's right. Yeah, right. It's like the discussion around, and Evan and I had this discussion, if you prohibit spread pricing by PBMs, there's a revenue loss and it'll be made up.
But as the legislature added money to the Medicaid rates last year, it'll be interesting to see if we bring down the commercial rates, because there's not gonna be the need for cost shifting as much. So just gotta say, it should go both ways. He's laughing at me. Oh, they're unconnected?
So should we go through?
Yeah, can we go through and just like, I think, I feel much better knowing administrative simplification is being done over at the commission. And it's not that we don't endorse that, but so I just.
Yes, let's do this. We tried to the extent that we could talk about the ones, identify the ones that were being addressed elsewhere, but we know this isn't a comprehensive analysis. So it would be great to just go through. Administrative simplification is being addressed by the Universal Healthcare Commission. Balance billing being handled by OIC. By Jane. Global budgets. It's gonna be in the analysis. Yeah, it'll be in the OIC analysis and a report coming out this summer that this group will hear about. Spread pricing, the bill is being considered now.
Wait, yes or no?
Well, it's not yet.
Not yet,
Yeah,
so.
it's working on it, but it's.
No, we haven't done, I wouldn't say we've done it.
So
it might hit the talk about.
Oh, the bill.
okay, so it's kind of in the middle right now.
It's on the second reading calendar in the Senate.
But I guess a question about this is, even if the bill doesn't pass, there is the PDAB. So I think the prescription drugs.
But they're not really gonna do anything about spread pricing. It's, I mean, that's specific drug pricing, like individual drug, yeah. But I don't think the issue will go away from the legislature, so you may not, I mean.
But we could.
So you could do
more
some,
there.
we could do, and we could support.
Hard to do, but we could do it.
So star that one and put it in the middle, or put it on the other side.
The next meeting, we'll know more.
If it needs to be added back. Okay, rate review authority. At this,
Well, I don't know. I know there's been some national interest of voluntary rate review kind of process with ERISA. And I don't know if Washington or the Alliance or PBGH has moved on that. I wish Greg was on. He might be back on it shortly. But there has been some call for, wouldn't it be interesting to try to set up a voluntary rate review process amongst the ERISAs? Very interesting concept.
Yeah, I don't think I would call this being addressed elsewhere.
okay,
So
so this is something that.
Okay.
Something that goes in the right column.
Goes in the right
good to
column.
know.
Yeah. Would change it. Yeah, okay, all right. And then mergers and acquisitions.
Kind of at the AGs, right?
Yeah,
But
that bill.
they are strength.
So it is being.
So it's in the right column. Correct column. Yes.
I think there's additional room over and above the bill that's currently. Maybe gaps.
Well, I guess where I struggle is how much more consolidating can we get? I mean, I know we can get more consolidated, but
It's the review of that. For information. Or.
and
Could be something like how Oregon and Massachusetts are doing it with their boards.
Well, and Oregon noted they are reviewing PE. Massachusetts said they don't have the authority to do that. So Michelle, is that what you were talking about?
That's private equity.
I just saw a note, Gary, I think you chatted something in, but it's gone. No, I saw it come up on the chat.
Yeah,
I
I did. It's gone already?
Well, why don't you just say it?
What I was gonna say was that, we can circulate this. There's a report from January of 2022 from the Congressional Budget Office that compares prices that commercial plans charge with what Medicare pays. And so it's just interesting to see what that gap is. But one of the conclusions in the report, which has been observed by in a number of other studies, is that the commercial prices are not correlated with the percentage of Medicare patients that a particular provider sees. So the idea that the reason why commercial prices are higher is because of cost shifting, because Medicare isn't covering or Medicaid isn't covering the cost of providing those services, is one that many healthcare economists really question as to whether that's actually what's happening, as opposed to what's happening is the commercial prices are, providers are charging what the market will bear. They're engaged in negotiations and they're getting, the best price that they can get. And it really isn't tied to, what they're, the revenue they're receiving from the public programs.
Gary, this is, I think, the ongoing, kind of this conflict between those that truly believe there's no cost shift that's legitimate, that, on the commercial side, they just can keep pricing up, and that it has nothing to do with Medicaid and Medicare. And I know from our WSHA partners and many others, they continue to say there is a cost shift and things aren't getting covered. So we have to make up on the other side. But we know from Gerald Anderson and all of his work of It's the Prices, Stupid, remember those series of articles but again, I think we're going to be having this ongoing kind of conversation forever about that very issue. But yes, CBO, to which I sit on that committee, we did do this review with the private equity and the kind of M&A and trying to correlate that. They have said nothing to do with it. There is no cost shift. That's not legitimate. It's just unbridled pricing in the wrong direction. Can we go down the not being addressed and just talk about where things are kind of occurring or where they're clearly, so like on private equity, clearly there's nothing being done on PE right now at BHGO or at OIC, correct? And nothing being done at DOH and or Healthcare Authority.
And the only thing is that the OIC report did talk about the need to increase reporting on it and transparency. Okay, that's it.
Limiting facility fees, I don't believe, and I'm gonna point again to Washington Health Alliance, if you guys are starting to think about how you're gonna break this out. You're thinking about it, but you're not doing anything currently.
Thinking about it.
Well, the only thing
And
is,
not publicly, it sounded like,
right,
so which means.
but it's the national, it's whether they do anything too on site neutral. The feds,
Yep, CMS.
we'll see.
Okay, so nothing on limiting facility fees.
Okay, with this, a big impact on consumers.
You're doing something on limiting or capping
This
tax.
is, this is something that Bob Murray has been talking a lot about. And he was gonna try to, they were gonna try to do, or they did some very, very gross modeling, not gross being bad, but high level modeling in Washington State. To see what would happen, but there hasn't been like a deep dive on Washington State and what would happen if out of network rates were a cap. And here again, the big issue would be, are you just doing it for the fully insured market? Are you doing it for fully insured and state purchased? And are there self-funded groups that would want to participate? Same issue. But this one hasn't gotten a deep dive.
Mark, I don't want to put you on the spot, you, Carol or Lois, but would you all be interested in this kind of activity about really diving deeper into limiting or capping out a network? Is that an ongoing issue? And I guess I'm gonna ask Drew back there representing other consumer or
Our people are required to go in.
Sorry, I didn't, you said.
Yes. It's already,
To go in
they're
network.
required to stay in network.
Okay.
And I don't know, Drew, if you know that about your membership, if they've got the out of network challenges, or most of them are already got pretty controlled narrow networks.
I'd say in Washington, the networks are pretty broad, so you don't hear as much concerns over going out of network. Not as many folks did what Costco did about 6 years ago, where they went to a PPO plan.
I do.
That made a big difference. But out of networks continues to be a problem because they have members out of state, and maybe in some locations that people say, well, I can charge you $100,000 for sinus surgery. Thank you very much.
Oh, and Margaret, I'm gonna go ahead and call on you. I see your hands up.
Thank you. I know we don't have too much time left, and I'd be really interested in getting to the favorite five of the members of the board. I'm thinking that even if somebody else is working on it, if we think it's one of the most important, then we should that it's one of our top fives, even if somebody else is working on it, because there's an opportunity to collaborate with them perhaps. So that's my suggestion.
Thank you for that, Margaret.
And Carol, what about you with the out of network? Are you asking that question too?
Yeah, I think, well, out of network, you know, in the more rural areas of our state, this is a big issue. And, I mean, we certainly would want to talk with our partners to make sure we're not taking away leverage from them, but it is a big issue for our members.
Kind of feel like we have the next thing, increased hospital price transparency underway, and really kind of have a lot of resources already committed to that. And I don't think any of us want to let up on that, given that that continues to be a big area. Community benefit transparency.
Don't have very good measures of that. I think there'd be a lot of interest in the legislature about working on that, having, especially on tax, because of the tax preferences. There's been discussions. Didn't they put something in a budget proviso for somebody to have to do some work on that though?
Jailer did a review.
Okay, I was like trying to remember.
Can I bring up one transparency thing that's not on here?
Sure.
And Gary and Liz, this came up when we were doing our report. And one of the things that David Sells didn't talk about is that Massachusetts requires hospital systems and any other consolidated system to report to the state on who is in their system and what affiliations are. And because we literally, when HMA was putting the consolidation report together, the preliminary report, they literally had to like search websites to find which clinics were affiliated with which hospital system. And so one question is, in order to accomplish any of these things, do we need to know who's in what system and which entity is affiliated with which PE backed? So that's something to think about. And there's a model in Massachusetts.
Also related to the benchmark, because we don't know what the entities at play, it's hard to figure out.
Right.
How we captured all of the entities, so it does play into other work.
So do we want to add a line, Jane, hospital provider transparency?
It's ownership reporting,
Ownership
ownership and
reporting.
affiliation reporting is really
Ownership reporting.
what
So
it
we're
is.
adding in there. It's in that, to me, it's in that bucket of mergers, acquisitions, private equity, of what's really happening. So it's virtually impossible to keep. I mean, we have months where things change over like within a 3 or 4 month period. We hear about something kind of, after the fact.
Do we want it as a standalone or do we want to put it in private equity? The mergers and acquisitions. Sorry.
I think Sue said mergers and acquisitions,
Oh,
sorry.
Well, they're all kind of.
Oh, it's in that whole bucket of,
We could add it to this.
yeah.
Well, probably not only private, probably like.
It's not,
Yeah.
it's all of them.
Yeah,
Right.
it's current and future.
So we're not adding a line.
I think we should expand it, align mergers, acquisitions, clarity around ownership.
And private.
Okay,
Okay. And then now we're in the box with all the green dots. Reference-based pricing, price growth caps, provider rate setting, consolidated purchasing.
In all
Long-term. They're all big, long-term ones and very
politically,
complex.
it's really difficult.
But difficult, but could have a very significant impact.
Sorry, can I just get a point of order? Are we trying to pick our top ones at the moment, or we're just
Right
trying
now,
to
we're
figure
just
out who's
discussing
doing them? or-
making sure
Make sure we
have-
understand.
Make sure we understand, not. Yeah.
Something.
We're gonna do an exercise in a few
Okay,
minutes.
all right.
It will be very sort of, not very scientific, but very clear. And then we're gonna do a dot exercise once we sort of
Okay.
eliminate a few of these that sort of we don't wanna talk, we know we're not gonna talk this.
But I have one question on the reference-based pricings for the public option. It already is a reference. Is it just?
We're just saying it's an example.
Oh, okay.
I'm gonna take that one.
No, we're not
Yeah.
saying that try to ratchet it down, which is
No,
a good
yeah,
idea,
foot in
but
the door. Foot in the door. I guess. Check one off. So. I think, is there anything going on with these items that we should know about or think about?
I think that given that, well, global budgets gives you a sense of what provider rate setting looks like. And that's one of the things that's going to be discussed by the board. It's like a different globe. And there might be some other work coming out of the final report that could inform.
there's been discussions about getting PEB and SEB together. Seeing if that might help.
So it sounds like there may be some conversations, but not a specific report or focus on that particular piece.
That's right.
We, some time ago studied, employer-sponsored public option, and I understand there's some interest in resurrecting that concept too. So not that that is something we're gonna tackle this next year, but since our public option is taking off, I think we're right under 60,000. There has been some interest in, does this group want to endorse studying that into the future? Creating a public option for our ERISA plans and partners, for ourselves too, for PEB and SEB.
So we should leave it in this column, just as urged.
Consolidated purchasing.
Something that people should.
Yes, yeah.
And I think that, the comments and the suggestions about things we need to look at, if we decide that these are one of the fives, we can flesh that out as we're making the work plan.
And I think that helpful on this box, and we can do it whenever it works for your agenda, but the big, complex, high impact, don't seem feasible in the short run things. It's just like talking about which of those models or approaches is this board most interested in? Because they're similar and overlapping, but just kind of, and acknowledging the feasibility challenge.
Right.
Is anyone doing price growth caps at all?
Rhode Island.
In other states.
Yeah, but not any of our agencies.
Not here.
Rhode Island.
And I would just say though, that when I know this is a future thing, but if this board, committee, whatever it is, got the ability, instead of fining, which I think the concern about that is that it just goes into raising the cost of healthcare, is to like set the growth caps as the punishment, I guess, if they're over benchmark, and just say that this is, you can't go any higher on this. So that's instead of like
Dollar.
Right, so that's what the Rhode Island person was saying, how. So they're just- they're growing fast.
Okay, And so just to confirm though, that we've moved, re-review and mergers and acquisitions to the middle-ish, not being addressed. And as Margaret pointed out, I mean, I think if I see your hand up again, it just, you know, if you think that we should still address it, even if it is being addressed somewhere else, I think that's fine. This is your board, this is your work. So Margaret, go ahead.
Yeah, I'm very interested in the provider rate setting one. You know, decades ago, we had a hospital commission here. And my memory of it is that it worked fairly well. And then we have the experience with Maryland. And even though this is complicated and longer term, it would also simplify things, as was mentioned earlier. And I think we ought to take a good look at it.
Your question, I think mergers and acquisitions plus private equity plus ownership affiliation reporting is all on one. And it's in the middle. Because there are groups going down these trails, but it's probably gonna use more. But there's room for this.
So, did everybody hear
The
that?
proposal is to combine private equity and mergers and acquisitions and ownership.
Ownership
The
and
provider
affiliation
reporting.
Kind of like change
ownership and private equity on one line.
because we need to know what is the what, and it relates to the broader mission too.
So it's my understanding, we're not, you know, there's no magic rule. If we vote that there are 6 that we all harmonize
there's no
on.
magic rule.
So I think we want to get started to just try to get a sense of like which ones people are feeling like these are, yeah.
Could I add that to?
Yes.
All right.
Yes.
For
That'd be
my
fun.
M&A ownership and private equity, could we also, can exits be part of that conversation?
Private equity.
Yes,
exits.
Sure.
Yes.
Maybe not just private equity exits, but just, I mean, exits in general. I mean, it's the idea of acquisitions that then end up in closures ultimately. I think that happens a lot in the pharmacy market.
I think that's great.
Or tell.
Oh, yeah, it just happened.
Yeah, so we're not gonna do that. Okay.
So one thing I want to clarify too, because we have such major work already underway with enhanced primary care, we did not rank this. That's already kind of foundationally in motion with our committee. I think somebody already, I heard, but I'm getting a text about where are we with that. So I just want to just clarify that primary care is already foundational in our go forward work.
They're gonna bring some recommendations. to the
Yes.
task force.
Okay.
But can I, as we're talking about combining things, can I actually caution that I've seen this happen with groups before, that you just try, so if you're only gonna have 5, you pile it all into one thing. That doesn't work.
See where it, and just want to see what the temperature. Some might drop off.
Right.
It's like,
Yeah, temperature checking. So this is our temperature checking. So anything else before we move to this?
How are we gonna capture people that are on hybrid?
We're gonna ask.
Okay.
It's Margaret and Greg. Is anybody? on?
I don't see Greg.
I don't think
on right now. It's
I
just
did
Margaret.
texted him to try to get back on, but he had an emergency. So we may get him. I'll let you know if I hear from
And Margaret, are you okay telling us out loud? If not, you can text me and I could just add this.
Well, everybody's gonna put their hand up.
Oh, everybody-
Yeah,
okay,
it has to be right.
I'll just put a number there. You might have to come off.
So what we're
Thank
gonna
you.
do, what we're gonna do is just to at least winnow down. We're gonna do a fist to 5 exercise. So a 5 means, yay, I love this. A fist means, no, I don't think it's worth our time. Okay, and we go in between. What we're gonna do is tally everybody up and see kind of where it shakes out. And what the lowest 5 are, we're gonna just put those aside for now. And then we're gonna have the remaining, it'll be like 10, not 12. We're gonna just go around and vote with dots.
We're gonna
Just
put some things.
See where the
We're gonna
energy.
put some things
We're gonna
up
put
while
the
you do the
remaining
fist for 5.
policies up, yeah. So that is our approach to doing this. It's not scientific, but we just want to get a temperature for what people are thinking, where there's energy and interest in trying to dive deep on some of these things.
Ingrid?
Can I just advocate for that we land on a mix
Yes.
of low impact, low end complexity, something that
Yes.
people might happen in our lifetime.
Oh my gosh, sure.
The other end of the spectrum, I just don't want us to be all in one.
All in
camp or the
green.
other.
No, and I think saying that is part of the just sort of, as we're thinking about this, Ingrid's absolutely right. We should be thinking about a couple short term, couple medium term, maybe one, maybe two long-term ones. Think about things that might be able to build on one another. Political feasibility it's a reality, but I also think it's important to think about, are there things that can build momentum for along the way as we do one thing, it kind of builds momentum. Consumers see that about why healthcare affordability matters. So just kind of keep those things in the back. All right.
One more point of clarification. Are,
Yeah.
are we doing a first round? We're just trying to kind of get to
we
our,
know.
yeah,
So
and
is
then
it
we're gonna go up to.
And then we're gonna
give
go.
dots.
So first
Okay.
steps, we're gonna do the
Make
5
sure.
to 5. And if people want to close their eyes, they can. If they don't want other people to do it, that's fine.
This is being televised, okay?
Yeah.
We didn't.
We might just do it here, Carol.
Yeah, this, and again, we said this before, if we decide that if there's no final decisions, you're never coming back to this. This is just to kind of scope out what you want to spend your energy on over the course of the next year.
Okay, can I ask a question?
Yes.
How many was limiting facility? No, you can't charge them. Right?
Yes.
One,
Yeah.
but in the middle, in
There's
the
many.
increments are things like change claim submission, so you can figure out if there is a facility fee. We need to do a better job of sending. Is you strengthen the reporting of facility fee revenue to deal with. So
You allow it.
if you're voting to do what?
You allow it for like a month, not for a few standalone.
Right, you limit it to prohibition is off campus. So if we're talking about limiting facility fees, is it that whole
It's the
constellation of
universe.
what you could do with that?
Yes.
I assume so.
It's the
Okay,
universe.
thank you for the.
So by that. Again, it's just saying, this is a policy that we think holds promise. There's many iterations of how it could get implemented, drafted, whatever. And the work of the board is to study that policy in depth, look at the different iterations, and then make a recommendation. So that clarifies. Okay. All right. Ready? Okay, Teresa's gonna help. Oh, yeah, she's gonna add us up.
I'm gonna add you up.
What we're doing first is we're gonna read through the policies, okay, and you're gonna just do 5, 4, 3, 2, 1. You're gonna add it up. And then get connected to the spreadsheet. Rock out the 5.
You can rate anywhere between nothing, like,
I don't want.
I don't want this,
And I
5,
really
and
want
then
it.
2, 3, 4, 5, and 3 would be,
Yeah, I'm fine,
either
it's
way.
fine.
Okay, I'm sorry, I'm just not gonna.
we can vote as many.
Oh,
God. We're tracking the numbers. We're gonna walk through each one.
We can vote for
And you're gonna
Yes.
vote for each one.
If you get one with a lot of these, you might as well rule it out.
We're gonna
Yes.
take it off. We're gonna take it off the wall.
We're
voting
adding it
them
up
down.
real time because we're not all great at math in our heads.
And then
So-
you're gonna get a chance to prioritize those, the ones that we end up with, these lovely dots that Eileen is very excited about. Okay.
Great.
Sue,
Yes,
this is Margaret. Yeah, I have to leave in a minute, because I'm on East Coast time, but I'm wondering if I could just give you my top 5, because I don't know how to do the fist thing over the phone.
Okay. Go, Margaret.
Okay, so my number 1 is provider rate setting. Number 2, administrative simplification. Number 3, limiting out-of-network charges. Number 4, restricting anti-competitive contracting practices. And number 5, limiting facility fees.
And what was yours? I have provider rate setting, limiting charges, anti-competitive. What was the other one? Oh, you're gonna forward it.
Administrative simplification.
Great. Thank you.
Okay. All right, so are folks ready to do 0, 1, 2, 3?
Ingrid, are you
4,
ready?
5? Yep, okay. Great. So limiting facility fees. Three, I see 2 somewhere. I see number
Ranking,
2.
I think you can only.
Oh, no, we're not ranking.
Can I just, you're down to vote.
wanna do it.
Vote 5s the whole time?
Yes.
Yeah.
Yes.
This is not ranking, it's a ranking of the entire group.
Okay, so how many ones do I have?
I think it's eyeball it.
Dang bad.
Really?
Well,
I'm trying to.
We're trying to add them all up.
So we get it.
Okay, let's go over one more time to explain it.
Who wants one? So who means, so sorry, wait, go ahead.
This is the down vote, so it's not who wants one, right?
No, it's,
Let her
let
explain.
me explain. There's 5 means you really like a policy, you really want to study it. A fist means I don't care about this, I don't want to spend my time on it. So what we're gonna do, I don't think it'll make a difference. What we're gonna do is we're gonna read through the 15 policies, just read them off. Based on what you heard today, do you want to spend time on it? Yes, that's a 5. If you don't, it's a 0. If you could care less, it's a 3. So what we're gonna do is we're gonna add up everybody's numbers, and then the 5 that are lowest, we're gonna say, not a lot of energy around this. Then the remaining ones, we're gonna go around and put dots where we want. So that'll be more refined. Okay. Perfectly clear. Sorry. Okay. All right. Or they could just what? You could just do. Okay.
We could just
Want to vote?
Yes. Yeah, well.
You don't want to do just 5.
Okay. Okay.
And there's everybody. There would be a natural.
Okay.
3.
All right. Prerogative
All right.
of the board.
Yeah, everybody that likes limiting facility fees.
Yeah, we're going to the dots. We're going to the dots,
We're
right?
going to the dots.
We're going to the dots.
Everybody just
Gonna
take
vote.
a walk around the room and put your dots.
And the rules for the dots are.
You each have 5 dots.
Don't.
Don't get up.
Now we're.
So Liz, are you gonna explain the dots? Explain the dots. Everybody has 5 dots. Okay, everybody has 5 dots.
We can bullet vote, right?
What's that?
Can I bullet vote? With 5 dots on all?
Yes, you can put all your dots on
One
one
thing.
if you want.
I'm a legislator, I know all these things.
I like the strategy.
There was a name for it.
Yeah. Oh, I got it right here.
I don't think they have the other.
I got it right.
What was the other one?
The other one was the
reporting.
report.
But I don't think the reporting was.
You don't need to vote, right?
It wasn't on, who I have one here.
No,
We added it. We added it. It wasn't on.
I
Right.
would put it so far away, try and keep it on one wall.
They're light.
We're
All around.
That's dangerous.
There's some over here too.
Don't forget the ones that were here.
Yes, I did.
Sorry, I didn't write a recording. Just putting it, we have the markers. I don't know what
I got it.
foundations are.
It was,
Really just got you.
There you go.
Ownership
Ownership
reporting
closures.
and private equity. Oh, somebody did it. Well, there's some nice music for you.
Yeah.
We did it. Yep.
What are you?
Yes. Okay. Yeah.
You're doing good.
Yeah.
One over here.
Keep it all on one wall.
Or at least
better.
this.
This slide.
I feel like I don't know what I'm doing. No, I like that one too. Okay. You just don't have stickers. No, I don't have stickers. I don't remember now. My color is this. So you guys know what else? I don't think. And I need to put Margaret.
Yes, ma'am.
I've got one more to just think about it.
I know, I knew that. I knew that. I didn't want to work, but
Now I'm like.
join me on that plain greens. I'm a single one on there.
The PBM.
That's fancy.
I think that's the task.
No,
I listened to Margaret who said, consider it, I figured strike while the iron's hot.
Everybody delivered their thoughts?
Okay, there you go.
No.
Okay, provider rate setting, limiting charges, making competitive.
Get on there sometime.
You do it?
Oh.
Now,
Margaret,
tell me where the vending machine is.
Vending machines are upstairs.
You told me that, oh, they were.
Yes. Thank you so much.
Teresa?
Yeah.
We lost your screen. We don't. When
Well, I
she
know I
started
did.
popping up.
Margaret, but I don't know.
Yeah, I think it is. I didn't know it's being talked about. What did that one?
Yeah.
Like crazy prices.
I think it goes with those.
But, well, it's actually a little bit different.
Oh, yeah, absolutely. I was just emailing myself, were you waiting to pay some bills?
Oh, yeah.
So send it to Teresa. Yeah, Teresa wrote it down, but she, we're having problems.
Oh, no, here it is, provider rate settings.
Got that one.
That one, limiting charges, anti-competitive.
I already have it.
Okay,
And then add charges, that's that one. We did that one. No, that one. This one? Yeah. Provider rate setting.
Add to.
Yeah, like. I'm good. I just like you're getting. Oh, yeah. You might do better not being blinded by the light.
Moderating.
Oh. That was the limiting.
Limiting facility. Okay, you got it? All right. Yeah.
You have some more mounting music now. Right?
Oh, you all right? Yeah.
That's right.
State funding for our.
Existing on all sorts of stuff.
Are you doing locally or are you?
Are you staying tonight or are you heading back? Just under 2 hours.
Okay, yeah.
My husband directed me.
Oh,
And there are. And there are.
Oh, fun.
I'm 58, 57. You know, we never do it. We try to come back. We have right next to the calendar.
Well,
I found out about it a few months ago.
What?
Yeah, yeah. We've known of her. Switch over. Do you want to announce it for the camera?
Yeah.
Well, I guess, I think she's gonna cover.
Oh, okay.
No, she'll be cutting with the rings. So we gotta take a quick break and be right back in 5 to 8 minutes.
Like an event.
Yes.
Oh, wow. I hope it goes well.
Yeah. He found out about him
So-
weeks ago and was
Yeah,
on their
there's
phone
that.
that day.
We have reopened the lines and I think we have audio and we have, I know Greg Marchand has rejoined and just gave us his kind of vote preference. We've got Margaret's vote preference. So we just are getting kind of, this is a general, we're using a chainsaw here to narrow. And we can get more surgical as the months and years go on, but we're not eliminating anything. We're just really getting that feedback of where were the highest priorities. So I would ask Liz and Teresa maybe to report out about how.
Oh my God.
How the voting kind of looks as we.
It's a real retreat.
A real retreat.
People are making it their own. So, okay, so there was one thing that happened. There was a combined, two policies got combined. Price growth, price growth caps and or price caps, most current price caps and price growth caps are directed towards hospitals.
Was combined with provider rate setting policies during the exercise.
Yeah.
So if you voted for one or the other, they got combined.
Any concern about
This
that?
one was combined too.
Yes.
That one was
That one
combined before we broke into the exercise.
So just wanted to make sure people.
And for those that are listening in and can't see, the one that Ingrid just talked about was mergers, acquisitions, ownership, private equity.
Yes.
I kind of got bucketed for how the state could get more
Visibility.
more visibility.
So the ones that rose to the top, number one, but there's 5, limiting facility fees. So that's one that folks really strongly endorsed. It's over here. Restricting anti-competitive clauses in healthcare contracting.
So wait a minute, I'm just gonna repeat. So the one that got the second most vote was restricting anti-competitive clauses in healthcare contracting.
No, that's just number this. Oh, okay, yes, okay. So restricting anti-competitive clauses got 7. Limiting facility fees got 8. Mergers, acquisitions, private equity, ownership closures got 7. Provider rate setting, policies and growth got 9. So that's 4. The other ones all were 2, 3, 4. So there seems to be a lot of energy around those.
For policies, or do we want?
We can add we have the
Well,
voting here.
So that's 4 policies, 2 of which were combined. So it was 5.
They're deep enough.
Yeah.
And
What was four? Was a combination of the price. Price growth caps was right there, provider rate reporting.
Why don't I?
Limited facility. Maybe put.
No, I'm sorry. No, let me restate that again. What was the one that got 4 dots?
4 dots.
Oh, a
few of them got 4 dots. Okay, I'll read the others. Increased hospital transparency got 4. Okay. Limiting or capping out of. Administrative simplification got 3. Prohibition on spread pricing got 1. Frequency pricing got 2. Further consolidating, expanding state.
That was the one that got 4 dots. The last
There's
one
2
you
that
said.
have 4. Increased hospital transparency and further consolidating. The ones that got the highest, I'll just read them one more time so everybody can hear. Provider rate setting got. Limiting facility fees got 8. Restricting anti-competitive clauses in healthcare contracting got 7. Mergers and acquisitions, private equity ownership closures got 7. So there's 4 that are 7, 8, 9. And then there's a couple 4s, and then the rest are like 1, 2, or 0. So do folks want to stick with the 4 that gain the most votes, or do we want to do the ones that are on the 4?
And again, we can look at these, do a deep dive into these, and if we go, wow, we've solved this, we can then pull up the 2 number 3s and go, which do we want to do now?
What I would recommend is take the top four and they're all kind of the same, just
They're
call
all
them the
kind of
top
the same.
four.
Yeah.
And then think about, like, when we talked about the criteria of a mix of like near term, perhaps doable versus very complicated, more long term. And like other people working on versus this board, value, unique value add. See what the mix is, what's missing, and then that could maybe point to a 5.
Okay.
There might be something that is missing that we need to pull up because it doesn't meet kind of the portfolio that we talked about once. You did combine some policies too, so technically you have like 7 by count, so it's actually okay that you have 4.
Yeah, just make sure there's not all long or not all medium.
Digesting the top 4, and is anyone having serious heartburn that something is missing?
Well, another way to think about it too is consolidated state health purchasing. Any discussion of the top 4 is gonna have to involve whether it would be applied to state purchased healthcare as well. So that sort of would bring that in to a certain degree, right? Because you're talking about a consistent practice. Yeah. Like your implementation strategy.
Well, and Jane pointed out, pricing could affect the others. So I think what we'll propose to do now, Ingrid, is take the 4 that have some combined. We can take the criteria that we talked about earlier, the equity, additional criteria and lenses, and bring it back or send an email to the group to just look at it again. You've had time to digest. I don't think we want to do it today because we need to move on.
No, we'll just create a work plan based off your priorities, and get back to you. We'll mark it in terms of, we'll figure out what's the best flow of it.
What would build on?
Yes, exactly. For your review.
I would urge us to think about consolidated state purchasing, not narrowly in just having said, but to think about the construct of, given the landscape of what we're seeing with the public option, are there some other consolidated things that we could be brainstorming about or beginning a work kind of structure for the future? So I just think that's something we should be, since I've got 4 dots, I think it's something that we should look at either endorsing or digging further into.
And I think the Universal Healthcare Commission has it on its task list as
Okay,
well,
great.
so there might be room for the commission, for the board to support the commission.
They will.
Yeah, it
Right,
is on
project
the
They're gonna
list,
be
right.
looking at it.
So there actually is the opportunity there for the board to listen into the commission's recommendations on that particular topic.
We'll send it out in writing. Change it right now, just so you can see it on paper. I know that makes a difference for me. So, okay. All right.
So board members, thank you for that. I know it was a little chaotic. Thanks for being flexible and adaptable. Greg, you didn't miss anything. That was a little, like, we had music going on, but, and I'm sure.
Yeah,
It was good that we walked around. So I wanna move us along because we have a few more things that are really important. We wanna do a very short discussion on the board's committees and charters with Liz and Gary, because I think we, in our first evolution of getting this group up and going, we had, a lot of information flowing from our committees, and I wanna provide our facilitators, room to talk to us about how we might wanna structure that a little differently going forward. So Liz, over to you.
Sure. And Gary, jump in here if you want. So our understanding is that when the board was established and chartered, some of the committees were not necessarily chartered in their work, in their activities, which from what we've gathered can lead to some unclear expectations for members of those committees. So as we're going into the next phase of work and trying to look at potential policies that, the data are informing you all about what might make sense, and with a new focus of that on the board, we want to think about, is it time to charter those committees? Especially now that we've got a clear work plan in terms of studying different policies over the course of the year. Does this give an opportunity to be very clear about how the board intersects with partners? So, and also to just take advantage of the expertise that's on those committees. I think when expectations and roles aren't clear, it's hard for folks. And so this is an opportunity to sort of reboot and say, this is what we need from you, and just be very clear in your direction to them. So go to the next slide. You all have had draft charters that came around. I don't know if folks have had a chance to read them all. But this is sort of just to kind of lay out the sort of structure that we're looking at. And who's responsible for what. The role of the committees is to provide the expert guidance in response to the questions of the cost board. And another change would be that committee chairs will be established to bring the information from the board to the committee and back. So those are some changes that we're talking about in the charters. And there would be a nominating subcommittee for the cost board to do that. Any questions about what's proposed here?
I have one question about Michelle on the bill that's moved out of the House. There's changes, I know, in the committees. Is
It's
it
the
all?
providers and carriers, just
One committee.
Did they add more people?
yes.
Oh, Jesus.
A lot.
So one thing I'd like to
It might make you
Oh,
So one thing I'd
With
like
30
to suggest, because we do have 50 of these committee members that are out there that I think it would really help if board members would consider serving in a leadership role with some of those committees. So for example, Eileen, you'd be perfect for the providers and carriers to oversee that group. Not I'm just saying.
you're gonna give me a whip.
And then, Ingrid, you'd be great for nominating since we haven't really populated that committee ever, but we really need to, because we do see a fair amount of people coming and going. And then also for data, I know Edwin's not here, but he goes to that and either Edwin or Bianca, maybe, you guys could tag team that one, but it really has helped when, as you guys have seen Jody do this before, where she reports back. And I think that would help with committee work to kind of keep the charters and whatnot, so that we have kind of this appropriate communications both ways. So you don't need to give us an answer right now, I'll strong arm you later. But we do really want to continue to help our committees understand kind of their role in this as we have to keep doing this groundbreaking work.
I would also say that with the Universal Health Commission, Pam McEwen has been excellent liaison between the FTAC and the UHC, and has really provided that continuity and opportunity for those folks to feel engaged in the work and maximizing their expertise in the conversation. So it's been really beneficial. So I would really encourage that.
So I would just ask you all to either email or talk to Mandy or Michelle about your interest in that. And if there are others of you that want a committee, I know Kim, we can talk about all of you, who wants to do what. So please just let us know if you want to serve with any of these committees. There is a fair amount of work that goes on. The committees meet every other month-ish. There's a whole grid of the work that needs to go on in between. I think, and if I remind you, all of that was under tab 8 if you want more information or to haven't already reviewed that. I think we're gonna move on now to it's Sherelle, you want to come up, and if you want. We asked Sherelle Namanjet to give us an update on the 2024 data call, and welcome. Thank you for coming. I know you and Michelle have done a ton of work about moving this forward, so it'd be great if you could, for those on the phone, just identify yourself and then just share with us about where things are at.
Oh, it's just
Okay.
All right. Hi, everyone. I'm Cheryl Lamid. I'm the new Health Economics Research Manager and leading the data analytics for the board. I just joined in January. And we are getting ready to launch the data call. We're going to start sending the data call letters to carriers on February 12th. And that will start the call for 2024. And we are giving them 60 days to submit the data. And in between those 60 days, we are going to provide technical assistance to carriers and try to help them prepare the data and help them submit the data. And then we allocated about 3 months to conduct data validation. And then we hope to finish by July and then start conducting the analysis, August. As well as generating the carrier and provider reports. We hope to send it to carrier and providers for feedback, and then generate the analysis or do the analysis and report to the cost board. So that is the timeline that we are expecting for this year's data.
That is great. And just remember, guys, this is our second time we're doing this, so it's gonna be easier than the first, we hope. Those of you that do business though, with some of the folks that had a hard time last year, Mark, if you could tell Aetna, hey, this is coming up, you really need to feed. It's really important on that total health expenditure for us to get that statewide-ness. The Amerigroup was the other group that we are just really wanting to work with. So this year, no glitches, no delays, and we don't get backed up. So thank you, and Vishal, to your team that keeps moving this forward.
Hey, quick question. Can you remind me what years of claims data you're gonna be pulling?
Yes, so for the 2022 data call, which was done, the first one, we collected 2017 to 2019. So for this year's data call, we are collecting 2020 to 2022. Claims.
2022 will be our first benchmark year.
Got it. Okay. Good, thanks.
It'll be interesting for sure. All right, we are at the part of our meeting where we open up lines and take public comment. I understand we have quite a few people. I want to honor the people that have been here in the room. Oh, wait, did I miss somebody? I missed Joe. No, he's not on the agenda. Is there anything to bring? It's just here. Okay. He was giving me a thumbs up.
Happy to talk.
So we might want to take a break just because public comments is not scheduled for a little bit. So if anybody needs to take any additional time or.
That is good.
Are there
Look at
people
that.
on?
There are,
Well,
but we can
start
begin
with
with
it.
people in the room, actually. That won't be a problem. Because we've got their.
Yeah,
they're
I'm
already
getting
here.
text
So
of
actually,
people
we'll go ahead and do that. But
waiting.
that might take just a quick second because we just got the slides in for you. We'll just need to change it up.
So again, those that are with us hybrid, we are gonna pivot and move to public comment. We have plenty of time, and that way we can just allow for a little more time for each of our speakers. I know Mandy and her team are getting me the list, but we will begin here in the room. And Drew, I'm gonna invite you. You've been with us all day. If you want to come up and join the board. So for the general public, I want to remind you that we take written public comments all the time. And they, board members can be found under your tab 10. Individuals that have signed up or here in the room, we like to have you begin by identifying yourself and your affiliation. Those of you that are on hybrid, we ask you to raise your hand, and Mandy's going to kind of get the order set. And I think after Drew, I'll call out who's on deck. I think Elizabeth Mitchell will be on deck after Drew. So Drew, why don't you go ahead, and Mandy, you and I will do hieroglyphics across the table as we get the list of folks wanting to contribute with public comment.
Great. Sue, thanks. I'm Drew. I'm the executive director of the Washington Health Alliance. Been with the organization officially for 1.5-ish years. I was on the board in 2006 or 2008 or something like that. So I've been around for a while. Lois, we are a small business. We have 9 employees. We have about 170 member organizations, so that are really what the Alliance is. Carol happens to be our treasurer, so I'm gonna make her go to work because I can. My background, I'm a family doc by training, and you have a master's in healthcare administration from the School of Public Health. I'm a little mad that you're not a member of the Alliance. I just thought I'd throw that out there. I practiced for 18 plus years. I was with an insurance company for 18 plus years, and so I can sit on both sides of the fence. But I wanted to just give you a quick comments, and I love the discussion today. But sort of thinking through from a cost and affordability standpoint, where we're at. If you go to the next slide, part of where we're going to go with the Alliance is, you were just talking about it, Sue. How do we leverage, bigger entities to be able to have bigger purchasing power? And I think from the Alliance standpoint, that's sort of where we're thinking as well. Purchasers, we believe, have the ability to leverage the market if they act collectively. So if they are trying to do it individually, they might be able to do really great things for themselves. But that's not gonna meet the needs of the larger community. We think the market has to shift. And we also believe that having multiple people at the table is the way you can get enough voices there to understand, where you're pushing that balloon and it's gonna pop out the wrong way. Let me go to the next slide and I'll just run you through some things that this is Drew's train of thought, so I apologize for that. And I'm just gonna tell you to click things. So there's a bunch of bubbles up here. There's probably 15 more bubbles that we could work on, but we'll just start with the ones up here. If you just click once, my mind, if we continue to pay for care that's fee for service, we're gonna keep getting what we're getting today. We're gonna get volume over value, and that's just not gonna be very good. So I think anything that we think about, we have to think about what's the payment model, and it came up over there too. Whether it's rate setting, global budgets, something like that has to be in place because you want people accountable for the care. You also heard from, I think it was Massachusetts, that, providers are saying, I don't want to take any risk. Well, what are the circumstances that would make it where they do want to take risk? Because places in the country that do take risk, those practices do better. We noticed that even when I was with Regents, a group taking episode payments, they did very well, as did Regents and Regents customers. So just taking risks can be actually a good thing. The second thing, as a family doc, I believe about primary care. Internally, we call this the path to 12%, because we think funding should be at least 12%. As a family doc, I think it should be 30%. Now, how much is it going to cost to get us to 12%? Well, we're only spending 5.5% right now. 12% is $39. Right down, and we're already in the whole $39. So how are we going to get there? Even if you try to figure out, what's the value of primary care, is it going to save money, or we're going to just post it that it can save 6.3%. Let's assume it saves nothing, right? You got to come up with $39. So one of the ways you can do that, if you click one more time, is you can steer people to the best practice. Excuse me, before that. Our data show that if you have claims and you don't have a PCP, you cost more. That cost is $27. So if you gave everyone a PCP on the commercial side, you get $27. So now we're only minus 12, right? Okay, you're doing the math.
I am.
Okay, just checking. Medicaid is it's $57 risk adjusted. So having a PCP matters, and it matters from a cost standpoint. What Boeing's doing and what others have done is they've embedded within primary care the ability to choose the right referral pattern as well. And there are vendors out there. PBGH has a vendor. There are other vendors out there as well that can provide concierge services to the right provider. That provider may, it's not the whole group. There might be 10 people in the group. It might be 2 people in the group. They may not be in the same health system. They may be in health system A, B, or C. We know MultiCare had to not refer to their own services because they were poor quality, poor cost. And guess what? Their own practice changed, and then they can refer back. If you click one more time, that gets you to sort of I call them centers of excellence, but it's really steering to best practice. Cost savings on those, 35%. So let's say that's $50. How are we doing so far?
Whoa, you succeeded.
We're at $38, right? I'm doing the math. Okay, that's not too bad. Click one more time. I want to see what comes up. We talked a lot about fair hospital pricing and whether that's facility fees, what's the break-even rate, et cetera. We know that hospitals produce Medicare cost reports, so we can actually calculate what their break-even rate is based on their payer mix. So if they got 50% commercial versus 25% commercial, they're going to have different stresses within their system, rural or urban, et cetera. So we actually know where they should be priced based on what they report. If you think about facility fees, think about some of these other costs, and you understand that hospitals are and their outpatient departments 50% of the cost. Let's say you could save 8%. Okay. Not unreasonable. $20. No, I don't even remember what we're up to. So we're up to some number. Okay, click one more time. I don't even know what which bubble pops up. Okay, pharmacy. We were just talking about pharmacy and spread pricing. Spread pricing is one lever that the PBMs get. We had a customer in our office yesterday talking to a nonprofit total medical management vendor on PBMs. If you're above $60 to $80 PMPM, you're probably paying too much. This group was at 132 after rebates. They would save $10 million a year. And that's very conservative. So let's make it $20. Okay. So we're not gonna go all the way there because they'd probably save $40, $50 PMPM. Their Medicaid plans some of them are below $20. And I think yours is a little higher than that. We also think there's two other areas. One is measuring the impact of behavioral health. We talk about behavioral health access all the time. We don't talk about the quality more time, and it'll just animate for us. We don't know what the value is in there, but there is value in if you're doing therapy and you're not improving, you should be referring to a different type of therapy, or maybe you need medications or both. And there is the ability to do that as well. And then the last thing is really about equity. And equity, in my mind, has to be embedded in everything. It has to be embedded in your plan design. Some of your plan designs may actually make equity worse, but it also is part of quality and part of cost. So that's kind of where we at. I think it matches a lot of the things that you're talking about today. And I'm going to be really excited to listen to see what happens over the course with the 4 or 5 or however many numbers. There's a bunch of very colorful dots up there, and I'll stop and see if there's any questions. And what was our total dollar?
I
lost track. Oh, equity.
But I have
Equity will get $10 plus some gaps at 30% compliance. So what would we get to?
No, 88.
$88. And that didn't impact too many people. No one's gonna be mad about that.
Thank you, Drew, for those comments. All
Can I ask
right.
maybe one question?
Yeah,
I'm
you bet.
just curious about the centers of excellence and stewardship best practices. I mean, where right now do you see getting any, what are the centers of excellences that you are looking at now, if any?
It's individual providers. Because if you look at one of the health plans today and you say, what's my center of excellence? It's 70% of the providers. That is not a center of excellence. That's just your contract, right? That is how you contract. So a center of excellence should be the top 5 to 10% for providing the best results. And it's not the whole group. And every health plan that I know does it by either group or by contract with that health system, which is the most common thing that we see in this part of the country.
Which would be steering.
It's steering, I know, bad word, but don't you want to go to the best provider? Or you want to just go to the worst?
No, I'm saying
It's
the contract
different
with
with-
the health system called Center of Excellence, that's called steering.
Thank you for those comments.
I
All
do
right.
have Jeb Shepherd for public comments.
Actually, I think I had Elizabeth Mitchell on deck for number 2.
That's okay. Yeah,
Can we open up Elizabeth and then,
she is available to be.
because I know she was
Oh, sorry.
great.
She is.
Elizabeth, I think you're on.
Great. Can you hear me?
Yes.
Okay. Thank you, Sue, for the invitation, and thank all of you for your hard work. I got to listen to some of the strategies you're considering, and I think to Drew's point, it just shows how many opportunities we have to save money in healthcare while also preserving or improving quality. I am the president and CEO of the Purchaser Business Group on Health. We are a 501c3 nonprofit committed to affordability, quality, and equity. We've been at that for about 30 plus years. Many of the folks in this room are among our members. I'm so proud to say that, doing really innovative work in healthcare purchasing. We include both private employers like Boeing and Microsoft and Apple, but also public purchasers, including Washington Healthcare Authority, CalPERS, and other really just innovative public leaders. So happy to share some of that experience with you as well. But I also wanted to note that I am on the board of the Office of Healthcare Affordability in California, appointed by Governor Newsom, and we have spent the last year having many of these same conversations and thinking about a target for what would actually improve affordability for people. And we have pretty robust and comprehensive legislation. So we'll be looking at everything from primary care investment to alternative payment models, mergers and acquisitions, all the things that we know will make a difference in affordability. But most importantly, we have to set a spending target. And fortunately, in California, we have enforcement authority, so we will be able to hold the industry accountable. But right now, the board is grappling with what that target should be. There has been a staff recommendation of 3%. And it is my position that that is not going to achieve affordability, because in 5 years, healthcare will be 15% more expensive. And the folks who come to testify in our monthly hearings are suffering right now. A single hospitalization, costs them their car and then their job, and the human impact of the affordability crisis is really surfaced in these meetings. And we are really committed to being assertive, as I know you are, because this impacts people. The good news is that in our work at PBGH, we know that change is not only possible, but it is being achieved right now. Our organizational goal set by our board is flat trend. And we know it's possible because many of our members, including those in that room, have achieved that. And they've done it through many of the strategies that Drew listed. We operated a Centers of Excellence program for about 8 years. Some of our members saved up to 50% total cost of care and had better health outcomes. But to the point earlier, these Centers of Excellence have to actually be excellent. It's not just based on discounts, it's truly based on quality and outcomes measurement. And we know how to do it, and we know it works. We also have a really robust primary care initiative. Boeing, among others, is participating in that. And we are seeing early results of significant decreases in total cost, while also seeing better access, better quality, better outcomes. So we know it's possible, and that can happen not just in urban areas with competition, but in small rural practices. We've seen that in California. So we're just so supportive of this work. We're happy to support anything that you're doing, but really urging assertive and urgent work, because we know what it's doing to not just businesses and public purchasers, but to workers and their families. So thank you, and we'd be happy to be a resource at any time.
Thanks, Elizabeth. I know we're lining up a lot of the primary care work nationally with your leadership there too, and with the Alliance. So I know there's a convening very soon up in Seattle with many other purchasers. So I believe we're going to move on to our next commentator, and it's Jeb Shepherd. So Jeb, if you want to unmute yourself, and you've got the floor if you'll identify yourself and your affiliation.
Yeah, sure thing. Good afternoon, everyone. Jeb Shepherd, representing the Washington State Medical Association. I just wanted to do public comment. I wasn't planning on saying anything, but I just wanted to extend a huge thank you to the board for including administrative burden in your discussion and consideration for areas to focus on in 2024. As the Medical Association has noted in comment letters and in a presentation that we gave to you all back in 2022, wasteful administrative costs that do not improve clinical care are a significant driver of healthcare costs that shouldn't be ignored. And most people agree that, unlike some of the other strategies that have been explored today, could be eliminated without harming quality or access. At your last meeting, I provided an update from the physician community in the form of a letter and a couple very local pieces from the Seattle Times and Kitsap Sun around the challenges that independent physician practices are facing in today's environment. These practice closures that help to drive things like consolidation are a result of the same issues impacting physician practices across the state, across the country, and make it increasingly hard for our members' patients to find affordable timely and necessary medical care, and that includes administrative burden. We believe the best way to lower costs for consumers without harming quality or access is to make healthcare easier and more affordable to deliver. We understand that the Universal Healthcare Commission is looking into administrative burden, and we'll be making a set of recommendations in June. We're monitoring that very closely, and we're looking forward to the release of those. And we appreciate comments today noting that though some of this work is taking place in other areas, it would still be meaningful to consider these issues and collaborate with the other boards. Would like to flag that the charges of the board and commission are different, and so we'd urge a high level of coordination to ensure the focus of the recommendations of the commission are meaningful to the work of this board in terms of formulating recommendations that will be impactful in reducing costs. For example, the conversations to date at the UHCC around reducing administrative burden have been specific to Medicaid, and we know it's a broader issue than that. So just an appreciation for the board's interest in addressing administrative costs, and urge you to take on this challenge in 2024. Thank you very much.
Thank you, Jeb, for those comments.
More public comments, so they could close and it'd still be okay now.
All right, so we do not have any others in the room, and we don't have anybody else online. I'll do one more call. Anybody else online? Are we sure the chat, that we checked that chat function?
Yeah,
That's
that
still
chat's
red. Okay, wow, I promised we'd try to get you out a little early so you can beat that traffic. I really want to thank everybody for coming today. I also want to thank our facilitators and our staff that put this together. We really appreciate your investment in this work and your opinions and your thoughts. I want to remind the general public that the recording and summary of this meeting will be posted shortly on our website. Thank you very much to all our presenters if you're still listening in, or if you're here in the room. I also want to remind you that our next meeting is April 10th from 2 to 4 p.m. As I told you earlier, Noam Levy, who was formerly a health journalist with the LA Times, is coming in. He's presenting down in Oregon, and he's agreed to come up and meet with our cost board. Noam has an incredible presentation. Drew and I heard him speak in Washington, D.C. It's all about medical debt and how employer-sponsored insurance is becoming the new social determinant of health. He will be sharing with us about the 105 million Americans that are now getting bowled over with medical debt concerns and how we have a duty to keep leaning into our work. So he'll be with us, and we'll get you more details about the agenda as it takes shape, but it should really be a great presentation. I look forward to seeing all of you. Those of you that are traveling, please get water, beverages, goodies for the trip home, and we will see you in April 10th, very soon. We are done. We're adjourned.